teachers and colleagues. We are Team 6 from Bangalore Medical College, and I am Dr. Yoga Ishwarya and my colleague Dr. Nagmallesh. Coming to our case presentation today, it is on ulnar nerve palsy.
There is a patient, 22 years old male from Bangalore, right-handed and delivery agent by occupation. He came to hospital with the chief complaints of difficulty in extending his left ring finger and little finger since 5 months, and there is an alteration in the sensation over the left little finger since 5 months. And he is also having difficulty in performing his daily routine activities with his left hand since 5 months. The patient gives a history of assault by a known person 5 months ago when he was attacked by a sharp object and he defended himself using his left upper limb, sustaining two lacerations over the left forearm. He gives history of profuse bleeding from the wound and went to local practitioner where primary skin suturing was done after achieving hemostasis. The wound then healed following regular dressings. He started noticing difficulty in doing his routine daily activities using his injured hand 1 week post injury. Patient noticed inability to straighten his left ring and little finger completely. However, he didn't seek any medical attention for the same due to personal reasons. There is no history of any physiotherapy or usage of splint. Due to past history, there is no previous surgical histories and no prior hospitalization or prolonged drug treatment, and there is no comorbidities. Family history is nothing significant, and personal history is not a known alcoholic or smoker. Coming to general physical examination, patient is conscious, oriented, and cooperative, moderately built and nourished. Head to toe examination normal. No evidence of pala rectus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals are stable, and systemic examination not associated with any diseases.
Coming to local examination, after obtaining informed consent, patient was examined in a well-lit room in sitting posture with both upper limbs exposed. On examination of the left upper limb, which is examined in comparison with the right upper limb, attitude of the left upper limb, shoulder is adducted and internally rotated, elbow is flexed, forearm is supinated, wrist is in neutral position, and there is loss of cascade of the left hand fingers. On inspection, two scars are noted in the flexor aspect of the left forearm. First one is horizontally oriented scar 2.5 into zero point 0.5 centimeter in the midline flexor aspect of the forearm around 5 centimeters from the elbow crease. There is another scar 4.5 into zero point 0.5 centimeter in the medial volar aspect of the forearm around 10 centimeters from the olecranon process extending into the extensor aspect. The scars healed well, hyperpigmented. Surrounding skin is normal, no sinus or discharge is noted. Left hand, there is claw deformity noted in the fourth and fifth digits, which is hyperextension at the metacarpophalangeal joints and flexion at the proximal and distal interphalangeal joints. Atrophy of the hypothenar eminence is noted. Skin over the ulnar aspect of the hand over D5, D4 and D5 are dry and shiny. Flattening of the palm and metacarpal arch is noted. Thenar eminence is normal. There is hollowing of the intermetacarpal spaces noted over the dorsum. On palpation, all the inspectory findings are confirmed. Scars are supple to touch and non-tender. Coming to the range of movements, shoulder and elbow is normal. Wrist, flexion, extension, ulnar and radial deviation is normal. Metacarpophalangeal joints, passive flexion and extension is normal. No active flexion of fourth and fifth digits are noted. Active extension of fourth and fifth digits are normal, while active flexion and extension of other fingers are normal. Proximal and distal interphalangeal joints, ring and little finger active extension is reduced, but range of movement increased on stabilizing the metacarpophalangeal joint. Flexion of the interphalangeal joints are normal. Other fingers flexion and extension is normal. Adduction and abduction of the fourth and fifth digits are normal. Lost from index to little finger. Coming to sensory examination, sensation over the thenar, index finger, middle finger, and radial half of the ring finger, radial two-third of the dorsum of the hand is normal. Sensation over the medial one-third of the palm, dorsum, little finger, ulnar half of the ring finger is altered. Temperature is decreased in the fourth and fifth digits, hypothenar area in comparison with the right hand. Crude touch is decreased, fine touch is decreased, 2-point discrimination is lost. Sensory examination MRC grading is S0. Tinel sign is present in the scar over the medial aspect of the forearm. It is non-progressive. Coming to motor examination, the muscle power by MRC grading, we can see that the metacarpophalangeal joints of ring finger and little finger flexion is reduced. There is a reduced extension of the interphalangeal joints of little and ring finger. Coming to vascular examination, the radial artery is well palpable over the left hand. Ulnar artery is not felt when radial artery is obliterated. In this video, we are demonstrating Allen's test. When the patient is asked to repeatedly clench his fist and fingers and obliterating both radial and ulnar arteries. Initially, when the ulnar artery is removed, obliteration is removed, there is still blanching of the palm. Only after removing the pressure over the radial artery, the normal color of the skin is noted, which is also denoted by the pulse oximeter signals. Coming to the clinical signs, Froman sign here on asking the patient to hold a book with the thumbs. There is IP flexion of the left thumb noted, denoting paralysis of the adductor pollicis. There is another sign, gene sign, where the patient is asked to perform a forceful pulp to pulp pinch of the thumb and index finger. We can see there is a MPJ joint hyperextension of the thumb, which is denoting unopposed action of the extensor pollicis longus. When the patient is asked to do forceful pulp to pulp pinch of the index and thumb, there is normal spindle shape is lost, and there is flexion of the thumb and index fingers over the interphalangeal joints, which shows a deformed Bunnell O sign, which denotes paralysis of the first dorsal interossei and paralysis of the adductor pollicis. Inverted pyramid sign is noted over the palm near the thenar eminence, showing atrophy of the adductor pollicis. When the patient is asked to move the middle finger sideways, he is unable to do, showing the petrous testis sign is positive, denoting paralysis of the dorsal interossei. When the patient is asked to grasp a card in between fully extended fingers and he's asked to pull the card with resistance, he's unable to do it, denoting palmar interossei is paralyzed. This is card test positive. Earl blasto sign, when the patient is asked to cross the middle finger and index finger over each other, he's unable to do, showing palmar and dorsal interossei paralysis. When the patient is there is involuntary abduction of the little finger, and he is also unable to adduct the little finger, which shows paralysis of the third palmar interossei, which is called as Wartenberg sign. There is hyperextension of the metacarpophalangeal joint and flexion of the interphalangeal joints of the little and ring fingers, which is Duchenne sign, which denotes unopposed action of the long flexors and extensors of the D4 and D5. When the patient is asked to forcefully abduct the little finger, there is no evidence of dimpling of the skin on the ulnar border of the hand, which is normally present in the right side. This denotes Momentaler sign is positive. It shows paralysis of the palmaris brevis. Massage sign, where there is flattening of the transverse metacarpal arch. The patient is unable to cup the hand, which is normal in the right side. And when we place a ruler over the knuckles, over the dorsal aspect, normal angulation which is present over the right hand is not present in the left side. Andre Thomas sign, when the patient is asked to extend the IP joints of the fingers, he is also flexing the wrist, which is due to habitual tenodesis. Andre Thomas sign is positive. Pollock sign, when the patient is we ask the patient to actively flex the DIP joints of the ring and little fingers, which is negative here. He is able to do it, which shows that the FDP of fourth and fifth digits are normal. Failing ulnar hook sign, here it is negative. Ring and little finger active flexion is noted against resistance, showing that the FTP of D4 and D5 is normal. When the patient is asked to place the ulnar borders of both the hands and against each other and asked to push it, he is unable to do, and there is little finger buckling noted in the left side, which is the abnormal side, telling that the confrontation testing is positive. It is due to hypothenar muscle atrophy. Coming to the measurements of angles, deformity angle is measured at the metacarpophalangeal joint and proximal interphalangeal joint. Ring finger metacarpophalangeal joint angle is 130 degree. Proximal interphalangeal joint is 150 degree. Little finger is 110 in metacarpophalangeal joint and 100 degrees in proximal interphalangeal joint. The unassisted angle is measured at the level of proximal interphalangeal joint, which is 120 degree in ring finger and 100 degree in little finger. Assisted angle is measured at the proximal interphalangeal joint when the examiner stabilizes the metacarpophalangeal joint. Here, the patient is asked to extend the fingers. Here, he is able to do complete extension, showing that the angle is 0, which shows that it is a simple claw hand. Coming to Bovier's test, patient is asked to extend the interphalangeal joints of the ring and little finger after stabilization of the metacarpophalangeal joint. Here he is able to do, so it shows type 1 simple claw hand. Coming to the diagnosis, he is a patient of post-traumatic left low ulnar nerve palsy, class 5 Sunderland, with partial claw hand deformity. Should I continue, ma'am?
No, I think a lot of questions on this, but anyhow, 10 minutes is the time.
Yes, sir.
You want to continue? I think my colleagues will tell whether they want to continue now and then.
Can you just tell me?
Stop now and then ask questions.
Can you just tell us the diagnosis, the duration of how many months?
Duration? 5 months duration, sir.
5 months duration.
Yes, okay, sir.
Yeah. See, I have a very basic question. You have told so many signs.
Yes, sir.
But ultimately, each one, what it interprets is something which is important.
Yes, sir.
It would have been nice if you tell in little finger and ring finger whether FDP is acting or not.
FTP is acting, sir, which is denoted by failing ulnar hook sign and
yeah, that's what you instead of sign. Supposing yes, you tell FDP of little and ring is acting.
Yes, sir.
That will convey it much better.
Yes, sir.
FDS is acting. FDP is acting in little and ring. Period.
Yes, sir.
That will give you more clarity.
Yes,
second
sir.
point. You said assisted angle is 0.
Yes, sir.
That means the PIP joint is fully extending.
After stabilization, sir.
Yeah, that's what I'm saying.
Yes, sir.
After stabilization, fully expand.
Yes,
in
sir.
which case, Bouvier cannot be positive.
So, Bouvier is positive, showing it is...
How can it be? The same thing. Both the places you are assisting, you are holding the MP joint. When the PIP is fully opened.
Yes, sir.
That means 0, it is.
Yes, sir.
They cannot contradict each other, what I'm trying to tell. I don't know about the patient, but
yes,
they
sir.
cannot contradict each other, saying that it shows some amount of flexion. It cannot, because assisted angle is 0.
Yes,
that means Bouvier must be normal.
Yes, sir.
Yeah, here the most important point is FDP acting or not.
Yes, sir. FTP is acting, sir. Ring and little finger.
Okay.
What is
because
your,
that is what is going to be more relevant than all these tests names, different tests. And since you have told these names,
yes, sir,
I would like to mention it to you. With a test tube time, you
yes,
must extend the finger up and then move, not keeping it flat on the table. If you keep it flat on the table, yes, then sir, it is Egawa test.
Okay, sir.
You understand my point? You showed
yes,
keeping the hand on the table.
Yes, sir.
If you keep it on the table and move the mid finger, it is Egawa.
Okay, sir.
Yeah. Okay, can I have 2 more questions?
Yes, sir.
My colleagues, I'm asking.
Yeah. Yes, sir. Yes, sir.
Yeah. Is this what you call it as ulnar less deformity or more deformity?
It is
It is more deformity because low ulnar palsy will have
Does it show more deformity or less deformity?
more deformity.
Uh-huh.
Where is the level of the
What is
scar?
ulnar paradox?
ulnar paradox is seen when there is high ulnar nerve palsy, sir. When FDP of ring and little finger is also lost. So the clawing is due to unopposed action of the flexors, that is FTP of the ring and little finger. When that is also paralyzed, there will be less clawing. That is called as
Less
ulnar
deformity.
paradox.
Less
Yes,
deformity.
less deformity.
That's why I asked you the question, is it a less deformity or more deformity?
It is
You
less
said more deformity.
Yes, sir. It is more
Actually,
deformity.
it is less deformity because the distal interphalangeal joint is not involved.
Yes, sir.
Is it up, high or low now?
It is low ulnar nerve.
Low. FDP is not acting, you said no, or acting?
FDP is acting in our
sir.
patients, sir.
So it is, okay, I agree. Then FDP is acting, yes.
Yes,
So
sir.
the deformity is more, so it is not ulnar paradox. Correct.
Yes, sir.
When do you say high ulnar palsy or low ulnar palsy?
So in high ulnar nerve palsy, one is the clawing we see. The clawing is more prominent in low ulnar nerve palsy, and there is also a paralysis of the flexor carpi ulnaris and also flexor digitorum profundus of fourth and fifth fingers. When that is present, along with other loss of intrinsic muscles, it is high ulnar nerve palsy.
In this case, it is low or high?
It is low, sir.
Low.
Then how come the FDP is working?
Because it is low ulnar nerve palsy.
Okay.
FDP is paralyzed in high ulnar nerve palsy.
Correct.
Yeah, correct.
FCU, you never mentioned. FCU is acting or not acting?
FCU is acting, sir. I mentioned in the range of movement, sir. A range of movement.
Both
You
radial.
are running, actually, you are very fast. So it was very
Sorry.
difficult. That's why ultimately, when you have finished everything, it is much better to tell the salient features like FDS is acting, FDP is acting on both little and ring, FCU is acting, therefore it is low ulnar palsy.
Yes, sir. Sorry.
Post-traumatic low ulnar palsy.
Yes, sir.
Why is it important to differentiate low versus high? Why sir is asking about this?
Sir, in high ulnar nerve palsy, the management we do is different from low ulnar nerve palsy because the level of injury is high, so the recovery time is much prolonged. So we might also have to do adjunctive procedures along with repair of the nerve, like nerve transfer. We might have to do it, sir. So that is why we have to differentiate whether it is a high or low ulnar nerve palsy. And we also have to uh, do tendon transfer. In doing tendon transfers, we should also think about doing something for the DP paralysis and also FCU paralysis.
Okay, we'll come to it when we come and discuss
Yes,
the
sir.
Yeah, yeah.
Yes.
That
Yes.
is management.
In the history, you mentioned about the clawing of the ring and the little. What is the duration?
5 months.
5 months, sir.
Do you think that immediately after injuries, the finger will go into clawing?
Yes, sir. It can go into clawing, sir.
Is it possible?
Yes.
Yes, sir. Patient will demonstrate clawing as soon as the injury is there, sir. He can demonstrate. In some patients where when the patient is having short, stubby hands and when he is well built, it might not be evident, but usually it is evident.
Correct.
Can you please elaborate the scarring? You said in elbow level, no injury. Where is
Yes,
the
sir.
scarring?
Below the
Can you
elbow region, sir. Yes,
below
sir.
the elbow? Below
Yes, sir.
scarring is where exactly? The
So
scarring
scar is present around 5 centimeters from lower down from the elbow, sir. There are
from the
two
elbow.
scars. There are two scars, one in the midline flexor aspect and another in the medial volar aspect of the forearm, around 10 centimeters from the olecranon process from the elbow joint, sir.
Okay. Still, you are telling it's low ulnar. Huh?
Yes, sir.
Last question. When the FCU is tested, did the scar move?
No, sir. There was no additions of the scar to
FCU
the
to the scar.
underlying.
That means FCU is not injured.
No, sir. FCU is not injured.
Okay. Ulnar artery is
Ulnar artery is not palpable on obliterating radial artery, sir.
And
talking about alternative, whether you are able to palpate ulnar artery.
So I was able to palpate ulnar artery, sir, but on obliteration of the radial artery, I was not able to palpate the ulnar artery.
That means the supply is not there from the ulnar side.
Yes, sir.
That means ulnar artery is injured.
Yes, sir.
That means flexa carpi ulnar is not injured, but ulnar artery is injured
Yes, sir.
at that level.
Yes, sir.
Oh,
and you said
very unlikely. That is a muscle level.
Yes, sir. Patient underwent primary treatment in a local hospital, sir, where primary closure was done. Probably the muscle was repaired and not the underlying neurovascular bundle, sir.
Vessel repaired, and then it's not stuck to the
It is
scar.
not stuck to the scar. Scar
Very-
is supple and normal, sir.
Okay.
Yes, sir.
Okay.
proceed.
Yes, sir. Coming to the management, I would like to do the following investigations: X-ray of the forearm, high frequency ultrasound or MRI can be done, nerve conduction study, electromyography, and routine anesthetic workup for the surgery planned. X-ray here, it is showing there is no evidence of fracture noted at the level of the injury. The nerve conduction study showed absent compound motor action potential and sensory nerve action potential in the left ulnar region, showing severe sensory and motor axonal neuropathy of the left ulnar nerve. Since nerve conduction study is confirmatory, I would like to proceed with the treatment. Preoperatively, I would like to give him dynamic knuckle.
But in the one of the slides, you mentioned that you will want to do an MRI and the ultrasound.
Yes, sir.
Why?
Sir, we can get a high frequency ultrasound, sir, if that is not confirmatory. Otherwise, MRI could be done for confirmation.
How will this investigation change your management?
So we can see the retracted ends of the nerve. Depending on the gap between the cut ends, I would like to know whether I would need a graft or primary repair would be enough, or any other modality would be needed.
So that the ultrasound will give you. What about MRI?
MRI would also give the status of the nerve, sir.
But why do you want to get these investigations done?
To check the status of the nerve ends, sir.
That you already said it is grade 5.
Yes, sir.
So then
It is a confirmatory study.
So normally you do routinely you do for ultrasound and MRI in all cases of nerve injuries. Suppose I say it is not required because in any case you're going to explore it.
Yes, sir.
Then
In acute cases, we would not ask for imaging, sir. In an old nerve injury, we can confirm a diagnosis, sir.
okay, proceed.
Suppose if you have to do only one test
Yes, sir.
in ulnar injury, which you will opt for? And what is the idea of doing X-ray?
The only one test would be Bouvier's test, sir.
No, no, no. I'm asking about the in the investigation part.
Nerve conduction studies.
Why not EMG?
Sir, electromyography will denote the muscular status, sir. Whereas nerve conduction study will tell us the nerve as such, the status of the nerve as such.
Which muscle you test generally for ulnar nerve?
Uh,
EMG.
we test for adductor pollicis, sir.
Have you told about Hinel sign?
Tinelson. Yes, sir.
Yes. So told, huh?
Yes, sir. I mentioned Tinel sign, sir. It is
Mention.
static, non-progressive at the medial forearm scar, sir.
Yeah. Only thing is you said tinal positive,
Yes, sir.
but it is not tender.
Yes, sir.
It's not
How,
progressive.
how can it be? They are all contradictory statements. If tinal is positive, that scar must be at that area tender.
So for a Tinel sign, we
You have to tap. The
yes, sir.
tenderness
We
is
tap.
also on, on palpation. So if you
Yes, sir.
palpate and you find that normally it is tender. Both are, it doesn't matter anyhow. I'm just passing remark, that's all.
Yes,
You are
sir.
doing well,
Okay,
doing
sir.
extremely well. Go on.
Yes, sir. Preoperatively, I would like to give the patient dynamic knuckle bender splint till he is fit for surgery. Um, uh, our primary surgery would be exploration, and we see for the cut ends of the nerve and repair of the injured nerve primarily, with or without a graft if the nerve gap is more. Then I would also do like to do correction of the claw deformity by modified style bundle procedure using FTS of the middle finger, which is split into two slips and delivered through the lumbrical canals of the ring and little fingers, and is attached to the radial lateral bands of ring and little finger. If the patient still has no improvement for after the following procedures, I would like to do Palande procedure for intrinsic muscle function on a later date.
Hmm.
You have combined
Good.
both, the primary as well as secondary procedures together. Your patient has got 5 months old injury.
Yes, sir.
What will you do?
Sir,
Yes,
since it is
you
already,
will do it simultaneously or you will stage it?
sir, since it is already 5 months old, it is the motor junctions of the muscle units of the intrinsic muscles of the hand is already affected. So I would like to do a internal splinting procedure for the correction of claw,
Then
along
what?
with the
What is the distance between the tinal sign and the first motor innervation? The distance. What do you expect the motor innervation first to be?
so the nerve will regenerate at
No,
one to
no,
three.
forget that. What is the first muscle you expect it to regenerate?
Uh,
FCO.
First muscle will be adductor pollicis, sir.
Hypothenar?
Hypothenar, sir.
Is it before adductor or
It is before adductor, sir.
correct? So
Adductor
that may
pollicis
come.
is the
So
end.
the distance between that and hypothenar, what is the distance I'm asking? You have measured. Have you
Yes, sir.
measured or not?
Yes, sir. Around
Not around. You have measured means it is exactly
20 centimeters, sir.
correct. So
Yes, sir.
how much time do you expect it to take?
It will take
20 into 10. 200 days.
it will take more than 3 months, sir.
20 centimeter into 10. 200 millimeter.
200 millimeter.
200
Yes, sir.
millimeter.
200 days.
Roughly
Yeah.
around 6 months.
Plus
6,
30,
7 months.
roughly 230. Unless somebody really meticulously repairs like Bandari does very well. So it comes to more than 6 months.
Yes, sir, more than 6 months.
About 7 months, let us say, for it to innervate. Already 5 months over. So you expect it to regenerate by 12 months after injury, right?
Yes, sir.
So would you like to keep those muscles active?
Yes, sir. I would like to keep those muscles active, sir. After repair,
Not after repair, until now. Straight away, are you doing anything to keep the nutrition of the muscle? Whether it helps or doesn't help, always there is a controversy. But is there anything which you can do?
sir, I would ask him to do physiotherapy following the splinting and post-operative time period for the nerve to undergo healing. That is 4 weeks. After that, I would ask him to do active and passive exercises. Along with that, I would give him splinting, knuckle bender splinting post-operatively, and I would ask him to undergo stimulation, electric nerve
That is
stimulation.
what I'm asking.
Yes, sir.
That's what is the one which can keep, if at all, can keep it going. Okay.
In the
So
treatment you
how
have
good is the
written,
result in Alna now?
It is poor, sir, because ulnar nerve will innervate all the intrinsic muscles of the hand. So when it is injured, the recovery is usually poor.
At that level.
Yes, sir.
in the treatment part
Okay.
you have written exploration and repair of the injured nerve with or without graft. Do you
Yes,
think
sir.
after 5 months it will be possible to do a direct repair?
No, sir. Mostly, we will need a graft, sir.
You'll need a graft.
Yes, sir.
And one more clarification. You mentioned about the EMG, which
Yes,
muscle is to be innervated first and which we generally test for. That is abductor distae minimi,
abductor
Correct.
distal.
because
Yes,
that is the first muscle to be innervated.
That
yes,
is the
sir.
hypothenar area.
Yeah, that's right.
Yes, sir.
So
And last question. This
Yes, sir.
Palande procedure and the other procedure.
Yes,
If
sir.
it fails, you said Palande. Why should it fail?
Uh, Again, sir, the
So dynamic procedures, if at all it may be more or less correction, it doesn't fail.
sir, style bundle will only address the clawing, sir. It is not addressing the intrinsic muscle function.
Correct. I
Still,
agree.
the palmar and dorsal interosseous and all will not act even after style bundle, sir.
Then why
Which
not
is
do this first itself?
uh, we can do it, sir, if
Okay. Okay. In your idea of doing two,
yes, sir.
for the style bundle, which finger FDS you will use?
Uh, Sir, we can use
Not can, you.
yes.
What you will use.
I would use middle finger, sir.
Correct. Supposing you want to do Palande, which finger you will use?
Palande we use ECRL, sir. Extensor carpi radialis longus is used, which is
Palande, yeah?
yes, sir.
Yes, sir.
Uh-huh.
Yes, sir.
Extensor carpi
Next,
radialis
it's longus.
longus is used, which is
That's not Palande. Palande is 5 slips of FDS.
No, sir. It is ECRL.
That is the intrinsic.
in Palande procedure. Extensor carpi radialis longus is attached to tensor fascial lata graft.
That is the old one. That is the old procedure.
Okay, sir.
Later he has modified it into FDS into 5 slips.
Okay, sir.
Okay, sir.
I'll come to that later.
Okay.
Yes, sir.
Why I ask this question is, if you are going to use the ring finger, then the ring finger FDP must be acting. So that is very important.
Yes, sir.
Yes.
So in this case, it is acting.
It is
So
acting.
it is okay. That is why I said that what is more important to convey is whether FDP is acting or not. because it depends on whether you can use FDS of ring finger or not. If FDP of ring finger is not acting, then you can't use FDS of ring.
Yes, sir.
Yes, Dr. Sendil is asking something.
Doctor, any nerve transfers you know of before doing this? Do you accompanying with this? Do you know any nerve transfers in the distal forearm?
Yes, sir.
You
We
know,
can. Yes, sir.
Correct.
Nerve transfers are done in cases of high ulnar nerve palsy usually, sir. When the time period for the recovery is long, we have to keep the intrinsic muscles active. So for that, we can, in this case, we can do anterior intraosseous nerve to nerve branch to the pronator quadratus, that we can anastomose to the motor branch of the ulnar nerve.
Why can't you do that now?
Yes. So the point is, you said the reinnervation of the muscles, intrinsic muscles, is going to take time. No, you
Yes,
said
sir.
around 12 months. So why not do this procedure and do the transfer later on?
Yes, sir. We can, if we can see for the progress of the tinel sign following this procedure. If that is not progressing fast enough, we can opt for this option also, sir.
No, primarily, why not do?
Yeah,
That's what I was
primarily,
asking.
why not do it primarily? Say
That is
you repair the nerve and simultaneously you do this procedure, the nerve transfer. What is wrong or correct or wrong? Is it wrong or right?
no, sir. It
We
is
can
not
do.
wrong. We can do it, sir.
Doctor, what is SETS? Any idea? Any recent advances? You know, what is SETS?
It is into transfer, nerve transfer, sir. It is done to the end, to the side of
Sorry,
recovering
no, it is a supercharging. No, supercharging
supercharging. It
nerve
is
trans,
supercharging
supercharging
of
nerve trans.
the nerve,
Yes.
sir. Yes, sir.
Here I would like to mention that the results of distal nerve transfer in ulnar nerve injury, where we use the distal part of anterosseous nerve, which goes to pronator quadratus,
Yes, sir.
are generally not good. Okay,
Yes, sir.
so this transfer is in practice for last almost 2 decades, but
Yes,
it
sir.
has not become very popular.
Correct.
So it is, I think, it is not like the other nerve transfer which we do, like overline transfer or Somsek transfer like that.
Yes, sir.
This transfer doesn't give good results. So you should be very, very selective when you think for this nerve transfer. Safer course of action will be to do the, in higher nerve palsy, to do the nerve grafting.
Yes, sir.
If the graft length is less than 8 centimeter, but
Yes, sir.
if and the duration of injury is less than 6 months,
Yes, sir.
of course, if the patient is coming after 9 months or like that, 10 months like that, then you do the proximal nerve grafting for restoring the sensation, which is also very important because it supplies the working surface of the hand.
Yes,
And
sir.
that time you can consider for doing distal nerve transfer, but it should not be made routine, even in higher
Primarily.
ulnar nerve palsy. For those cases also who present, for cases who present early. It
Yes,
is
sir.
only for the very, very late comers, 9 months, 10 months, and we don't have any other option. Better to go for later on for the tendon transfer. It is not
Yes.
a good nerve transfer that I wanted to mention.
Correct. One more thing, one more point is the nerve transfer and direct anastomosis or nerve graft. What is the advantage of nerve graft?
So nerve graft, when the gap, nerve gap is more than 3 centimeter, nerve
No, no,
graft
no,
is
no. Sorry, sorry, sorry. I'm asking about nerve crossing and direct repair. Nerve crossing, where are you going to anastomose it to? At what level?
nerve
transfer.
nerve transfer is done at the distal forearm level, sir.
Where?
Uh, we if we are taking nerve to pronator quadratus, anterior interosseous nerve, that is divided distally, and the motor branch of the ulnar nerve, we'll find it near the Guyon's canal, sir. that we divided proximally. Only the motor branch is taken from the ulnar nerve, which is anastomosed to the anterior interosseous nerve branch.
Correct. So, supposing if it is a direct repair, what is the advantage? Direct repair or nerve graft, if it works, what is the advantage?
So direct repair will always be beneficial when the vesicles are aligned correctly, and the renovation of both sensory and
Yeah, that's the
motor.
point. Sensory also will be
Yes, sir.
better, but in nerve crossing, you are only doing it to the motor.
Motor branch.
Doctor,
Why
Doctor,
the
what?
results of nerve transfer in ulnar nerve injury are not good?
Uh,
We are
because
we are doing transfer so distally at the wrist level, very
yes, sir.
close to the muscles. Even then, the results are not good. Why?
Because the intrinsic muscle neuromuscular junctions are will already be they will be not functional, sir.
Now I'll give you a hint. What is the which branch are you taking, which supplies that muscle?
Motor branch, sir. Deep
Which
motor branch.
supplies what?
It supplies the abductor polys,
The donor
abductor
nerve.
digiti minimi, opponens digiti
No, no,
minimi,
I'm talking the donor now.
donor nerve, pronator
Pronator
quadratus.
quadratus.
Pronator quadratus.
Yes.
How strong that muscle is?
Correct.
Yes, sir. Pronator quadratus will cause pronation at the mid forearm.
Negligible.
It is not strong enough to power all the intrinsic muscles.
So Dr. Bhandari has asked now
Yes.
why the results are not so good as compared to other nerve transfers. So I'm giving you a hint.
Okay.
Always remember, all recipient muscles, they do not behave similarly.
Yes,
All
sir.
donors are not as good as others. Certain muscles, they behave very, very good after doing the nerve transfer, like musculocutaneous nerve. It is the muscle which has got a single function of elbow flexion, and it responds very well to the nerve transfer, whether you use motor as ulnar or median nerve fascicle, whether you use intercostal nerve, or whether you use spinal accessory or phrenic nerve. So, there is certain inherent power of the muscle also which decides about the ultimate recovery. Intrinsic muscles are very, very poor to regenerate after doing the nerve transfer, So all muscles do not behave similarly. So that also we have to remember. Second is, of course, the quality of the donor nerve. Frontal quadratus branch is a very, very weak motor nerve. It cannot innervate so many intrinsic muscles. So
Yes, sir.
that's why the results of these nerve transfers are not good.
Yes, sir.
Doctor, can you tell the anatomy of the Guyon's canal?
Sir, Guyon's canal is located at the distal to the wrist. It is a 4 centimeter long canal. In between, it is bounded superiorly by the palmar
Superficial palm.
superficial palmar aponeurosis, medially and laterally by the hook of Hammett and the pisiform bone.
One second.
Pisiform.
Pisiform
Which is
is
medial.
and hook or hammer, both are on the same side?
No,
No,
sir.
sir. Medial and lateral.
Medially by the pisiform bone and laterally by
Lateral
the
by the
hook of Hammett.
Deep. What is the floor? Floor is formed by what?
Floor is formed by the hypothenar muscles.
Deep transverse. Deep transverse ligament.
Deep transverse ligament.
Ligament.
Yes.
And do you know how much motor fibers are there in Guyon's canal? In percentage of motor fibers in Guyon's canal?
So Guyon's canal, there are 3 zones. Initially in zone 1, it will have both motor and sensory nerve fibers. In the zone 2, there will be a motor branch. Motor branch is seen. And zone 3, there is sensory fibers, sir.
No, I'm asking you how much percentage. Suppose what is 50% or 50%, like that. How much sensory, how much motor will be there in a Guyan's canal? Because you'll be going for a now transfer and all.
Uh,
80% motor.
No, that is exactly not true. Actually, it is 35% only is motor.
motor nerve.
60% is sensory. Okay,
Yes, sir.
it is not opposite. Okay, right.
Yes, sir.
Proceed.
Shall we? Parvati ma'am, we have crossed 10 minutes, I think.
Lakshmi ma'am,
Sir.
will we continue
Actually,
or
total 50 minutes, sir.
Okay.
we have time or we have to finish?
Oh, you have time, some more time.
Okay.
So now you tell us, how do you decide the tendon transfer in ulnar injuries? What is the decision making?
So we need to address the disability. We need to address the deformities in this case, where there is a claw deformity. We also there is also a deformity of the intrinsic muscle. Intrinsic muscle functions are lost, and
Thumb pinch.
thumb
Thumb.
index to thumb pinch is lost. So we have to address all this. First, to correct the claw deformity, there are static and dynamic procedures. It is decided by Bouvier's test. When the Bouvier's test is positive, static procedures would be enough, and dynamic procedures would also be helpful. So in this case, I would like to do a dynamic procedure, that is modified steel bundle procedures. Other options are Zancoli lasso, and we can also use flexor and extensors. Uh, uh, wrist
Brand.
wrist extensors would be brand, that is EF40 or EE40, and Palande procedure can be done. Wrist flexors will be FCR, which we can use FCR also for to correct the claw deformities. And for coming to the index to thumb pulp pinch, we can address this by EIP, EIP transfer for the extensor, EIP transfer for the first dorsal interosseous, ECRP transfer for the first dorsal interosseous. Palmaris longus can be transferred to the adductor pollicis, and EIP also can be transferred to the adductor pollicis.
So I mean, what hand functions are lost in ulnar? What are the hand functions which are lost in ulnar? So
Sir, in our Indian
in our setup, what is the trouble which the patients have with the ulnar?
Yes, sir. In our Indian setup, patient would like to eat with his hand. So all the process of eating will involve cupping. Adduction of all the fingers, which is caused by palmar and dorsal interosseous. That is lost. So basically, we should address the intrinsic function of the palmar and dorsal interosseous. For that, Palande procedure would be better.
So in this case, you think the Palande procedure will be better for this patient?
Yes, sir.
Suppose this patient has come for surgery.
Yes, sir.
What will be the, how do you go ahead? What kind of anesthesia? How do you explore? And how are you going to repair the nerve?
Yes, sir. First, I would like to explain him what would be the procedure I would be doing, along with preoperatively what all he should do. That is, he should wear a splint, knuckle bend a splint, and he should actively uh, uh, extend and flex his ring and little finger. Then, after routine pre-anesthetic checkup, I would ask my anesthesia colleague to administer the appropriate anesthesia.
What anesthesia?
In this case, we can proceed for a supraclavicular brachial plexus blows.
Suppose if there is a requirement of graft, then which
Uh,
graft is usually taken? for repair of ulnar nerve or any nerve, peripheral nerve, which is the most common site to
Most
harvest.
common site will be sural
Sural.
nerve, sir.
So how your this block is going to help in harvesting the graft?
Uh, yes, sir. In that case, general anesthesia would be better, sir.
It is always when injury is 5 months and we know that there is a requirement of skin nerve graft. It is
Yes, sir.
better to do this surgery under general anesthesia.
General anesthesia.
And what all precautions you will take? Anything else? What is the basic requirement whenever we are doing peripheral nerve repair?
I, donor nerve examination, sir. If it is normal, in
A good hemostatic field is required.
tourniquet has to be applied.
Yeah, a proximal tourniquet has to be applied.
Yes, sir.
These are certain basic fundamentals, fundamental which we have to follow whenever we are repairing the peripheral nerves.
Yes, sir.
So it has to be done as anesthesia. Proximal tourniquet control should be there. And when you explore, where will you put the incision?
Uh, Sir,
The
in this patient, the medial forearm scar incision is the. I'm suspecting that is the site of injury.
Yeah.
So I would take a curvilinear incision over the scar.
What is
And
what is the basic principle in nerve repair? Means how you are going to reach to the site of injury.
neurolysis.
No. You
we
are
should
not
approach from the uninjured area
yeah,
first,
from
and then we
healthy
should
segments to the injured segment.
injured part.
So you have to raise flaps proximally and distally.
Yes, sir.
Okay, and then
Yes.
you reach to the site of injury. Now, how do you know that this patient will require a graft, or it is going to, or you will be able to do a direct repair? How do you decide?
Sir, once the site is explored and once we retrieve the proximal and distal ends, we see usually there will be a neuroma and glioma formation. So we must do bread loafing technique where we slice the nerve millimeter by millimeter till good mushrooming of the fascicles is seen. After doing all this, we should check for the now gap between the proximal and distal segments.
If the gap is more than 2 centimeter, we'll go with the graft.
How will you
More
check
than
that?
2 centimeter or less? More than 2 centimeter.
Yes.
Yes, sir.
What should be the length of the graft? Suppose the defect is 4 centimeter. What should be the length of graft?
Uh, Sir, at this level, the ulnar nerve will be little bulky. So, if we are taking a sural nerve graft, one cable would not be sufficient. So, maybe two or even three cables would be required. So, if the defect is 4 centimeter, then 12 centimeter of sural nerve would be required.
No. If the nerve defect is 4 centimeter, what will be the length of individual cable approximately? Is 4 centimeter only? It is less than that, or it will be more than that? If it is more than what percentage?
Uh,
You have to take more than the actual defect.
How much?
uh,
Generally, you should take 15 to 20 centimeter more than the actual defect. Graft should always be placed in relaxed position.
Relaxed position.
Okay.
20% more than the normal requirement. 20 to 30%.
Suppose the nerve defect is 1 centimeter, 1.5 centimeter or 2 centimeter. Will you do direct approximation, or there is something else available?
Neurolysis.
Sir, we can do a transposition. In this case, a transposition of the ulnar nerve anteriorly. It can be done from the
How can you do in the forearm?
no, sir. In at the level of elbow, in the olecranon region.
Here the injury is at the forearm, mid forearm level.
Yes, sir.
So that is ruled out.
Minimal, very minimal flexion of the wrist can be done, sir.
Anything is available for small
Neurolisis.
defects for the peripheral nerve, which are less than 2 centimeter or 2 centimeter.
Neurolysis can be done.
No.
Now condu can be used,
Yeah, very right.
saphenous vein,
No, not vein. They collapse. They should not be used.
muscle condu.
They are biodegradable.
Excuse me, sir.
Yeah.
Hello.
I think time is
Sir,
over.
actually, yeah, time is up, sir. So next,
Sir, please,
we can.
sir, Sanya, let's
Yes.
give answer, then
Yes,
you
yes, yes. Yes, sir.
don't interrupt in the middle. Sir, please proceed. Bandar, sir.
Yeah. I think she has answered well.
Okay, sir.
Both of them have answered well about the nerve conduit and all. These are biodegradable, made of generally the kind of material which vital suture is made. They get absorbed.
Lactic acid.
And the advantage of conduit, what is the advantage of conduit over the graft? What is the disadvantage? What is the main disadvantage of using nerve graft?
And donor site morbidity, sir.
Agreed. That is minimal.
Yes, sir.
Patients usually recover in 5-6 months' time.
Yes, sir.
In long term, there is hardly any morbidity. What is the main problem which is associated with the use of nerve graft? What is the advantage of doing direct repair?
In nerve graft,
Sir,
we have to suture at two sides.
nerve graft, in this case, sural nerve is a sensory nerve, sir. When we are anastomosing mixed nerve at this level, ulnar nerve will be mixed, having both sensory and motor fibers. So the sensory fibers will not provide.
No, the main I would like to tell you that the main disadvantage of using nerve graft is that at each graft site, because there are proximal and distal coaptations, two coaptations are there. At each coaptation site, there is loss of 25 to 30% of axons. So what ultimately reach to the distal part of the nerve is 40% only.
Yes,
so
sir.
most of the axons are lost at the site of coaptation. Okay, so this.
Okay.
Now, what is the advantage of doing conduit?
We can avoid donor site
Number one. Number two, suppose if you want to put grafts also, 2 centimeter or 2.5 centimeter or 3 centimeter graft to bridge a small nerve defect. What is the advantage of doing the conduit? These are not easily available, by the way, and they're very expensive also.
There will be no misdirection of the fascicles, which is reaching the distal.
Very nice, because the axons grow through the process of, what is that called? Sensory to sensory, motor to motor.
Yes.
What is that process called?
What is neurotropism?
Neurotype.
No.
What is neurotropism and
Neurotropism and tropism and trophism.
No. Sensory to sensory, motor to motor. There is no loss of axons. They are going, all axons are going in their respective places distally. That is called chemotaxis.
Yes, sir.
Isn't it?
Yes, sir.
So that is the advantage of. So you can expect almost full recovery if the defects are small with the use of these biodegradable products.
Yes, sir.
Yeah.
Okay.
But as a basic one, you are telling about the Allen's test. Okay, how is done regular Allen's test? You described in a different way. What is the regular Allen's test?
So regular Allen's test, we make the patient clench his fist and fingers alternatively till exertion. Then we obliterate both the radial and ulnar arteries. We should check for the patency of the arch, and for that, first we should release the obliteration over the ulnar side. then there will be already blanching of the palm. Even after, if the pressure is released and if the color becomes normal, if there is a normal blood supply which is seen with normal color of the palm, that shows that the ulnar artery is good and the arch is patent. When there is still blanching of the hand, we should also release the radial side. If the color of the palm is regained only after releasing the radial side, that shows the Allen's test is negative and ulnar artery is injured.
Is there any time durations there? Time
Within,
duration?
yes, within 30 seconds, there should be normal regain of the color.
Right. It's about 7 to 15 seconds it should come. 7
Yes,
to 15 seconds.
okay, sir.
We can move on.
Shall we move to the next session, sir?
Yes,
Okay.
ma'am.
Now the other team TGs will be asking questions to the presenting team. Team 1, Sanya.
Team 1, Madras Medical College, can I ask you questions?
Yes, ma'am. Good evening, ma'am.
2 minutes, sir. You present. You ask the question.
2 minutes.
Yes.
2 minutes for
What
one.
Yes, ma'am. What is the triple nerve anastomosis technique for sensory renovation of ulnar nerve?
Um, we have to anastomose to the sensory branches, which is one branch is to the common digital sensory nerve to the little finger. One will be to the one is palmar cutaneous branch, and another to the radial ulnar side of the ring finger. So anastomosis have to be done to all three branches.
No, what is the donor nerve used?
Donor nerve is branch from the palmar sensory branch of the median nerve.
No, to be specific, it is the third web space vesicle from the median nerve is anastomosed to the sensory component of the ulnar nerve. Simultaneously, end-to side cooptation of the dorsal cutaneous branch from the ulnar nerve is done to the sensory component of the median nerve. And since the first anastomosis is done end to end, there is to give the protective sensation to the donor site, the third web space nerve is again anastomosed end to side with the intact median nerve sensory part.
Okay.
Yeah.
Okay, team 2, Jitmar.
Team 2, Jupmar, my question is, can you describe the 5 grades of nerve injuries in Sunderland classification?
Really?
Grade 1 is neuropraxia. Grade 2 is axonal injury with intact endoneurium. Grade 3 is axonal injury with endoneurium injury with perineurium intact. In grade 4, all the axon, endoneurium, and perineurium is injured, whereas epineurium is intact. In grade 5, it is a neurotosis where epineurium is also injured. Grade 6 is a mixed nerve injury.
Okay, thank you.
Team 3.
Team 3, KGMU, Lucknow.
Good evening, ma'am.
Yeah.
Hello.
Ask the question.
Myself, Dr. Karthi from KGMU. Can you please describe the each contribution of Stiles and Bunnell in Stiles Bunnell procedure? What is the contribution of both the persons?
Initially, Style used flexor digitorum superficialis of all the fingers, and he anastomosed to the radial lateral band. Then Bunnell Bunnell modification is flexor digitorum superficialis. It is repaired to the both radial and lateral bands of all the fingers, which caused powerful extension. The flexors are used for powerful extension. So modified style Bunnell will the one which is commonly used is where we use one flexor digitorum superficialis of either ring or middle finger that we split into 2 or 4 slips depending on the type of claw hand, and it is repaired to the radial lateral bands.
Okay.
Next team.
Team 4, Stanley Medical College, Chennai.
Hello, from Stanley Medical College.
Yeah, ask the question.
Regarding this case, you have said you will do exploration and nerve reconstruction using sural nerve graft. And also you said you will use 2 to 3 sural nerve grafts. How do you arrange this? Whether you will place it from superficial to deep or medial to lateral? On what basis you will do this reconstruction?
On the basis of the topography of the injured region, depending on where the sensory and motor fascicles are. The motor fascicle should be renovated, coapted separately to the distal end of the motor fascicle, and sensory also should be coapted separately. Depending on the fascicular arrangement, the topography of the nerve, I would do the arrangement of the nerve fibers.
So, this level, injury at this level, that is middle of the forearm. How will the fascicles will be arranged? Like the topography.
Topography would be medially there will be motor nerve fibers. Motor fascicles will be medial, and laterally will be the sensory fascicles.
No. Actually, motor fascicles will be the middle. Medial most, that is ulnar most, is the sensory component. That is a dorsal cutaneous branch of ulnar. Middle one is the motor. And the lateral most is sensory branch to the web spaces and ring and lateral. So it's like a motor fiber is sandwiched between the sensory. So your arrangement will be 3 cable nerve grafts from medial to lateral or lateral to.
Okay.
Thanks.
Just a suggestion. In hand, it is better to use the terminology ulnar side, radial side rather than medial and lateral.
Yes.
Because it gets confused when you said medially the sensory.
Yes. Sir.
Okay.
Fifth team. Next team.
Team 5, AIMS New Delhi.
Hi, can you elaborate about the card test?
Card test, the patient is asked to hold the card with his extended fingers between 2 fingers. He's asked to hold the card, and the examiner also will do the same. The examiner also will hold the card in between the fingers, and when the examiner will try to pull the card, the patient should show resistance. If he is unable to do, and if there is flexion of the fingers, card test is positive, denoting palmar introitial paralysis.
Yeah, more specifically, both the patient and examiner will be in the
Examiner
same web
would be
spaces.
in the
But
same.
one of your slide, in your slide, it is actually wrong.
Yeah.
Yes. Thank you.
Thank you.
Next team.
Team 7, CMC Bellu.
Hello.
Team 7,
Hello.
CMC Bellu.
Hello,
Yeah.
ma'am. What is Martin Gruber anastomosis, and does your patient have it?
Martin Gruber anastomosis is it is seen at the forearm level where the fibers of the median nerve is it has connection to the ulnar nerve. Motor branches are connection to the ulnar nerve. In my patient, there is no Martin Gruber anastomosis because he also has loss of intrinsic muscles while the median nerve is intact.
Yes. Thank you.
Next team.
Team 8, Safdarjung, New Delhi.
Hello. What is Valerian degeneration? What changes happens in nerve in Valerian degeneration?
Valerian degeneration will happen at the distal distal segment where there will be glioma formation. There will be loss of the
Axons.
axons and the nucleus will be lost.
In proximal end, there will be 1 centimeter of degeneration, whereas distally complete the axons will be degenerated. Later,
What are the changes that occurs in nerve?
Not sure.
So there will be influx of extracellular calcium, and that leads to microtubule depolymerization, cytoskeleton breakdown, and axonema disintegration, which results in formation of cellular debris in the place of axon. And there will be marginalization of nucleus of the cell body, as well as the dissolution of nasal body. And these Schwann cells undergo metamorphosis from a supportive cell to a reparative phenotype, and release cytokines and neurotrophic factors, which attracts macrophages. And these Schwann cells and the macrophages together, they perform phagocytosis of this cellular debris, leaving endoneural tracts clear to accept the regenerating axons.
Okay.
Thank you.
Thank you.
Next team.
Team RML New Delhi.
Hello, am I audible?
Yeah.
Yes, you are right.
Yeah. Hi, this is Team RML. I just wanted to know if there are any described loco-regional methods for the correction of sensory or proprioceptive loss at the little finger, producing functional limitation at the ulnar border and chronic ulnar nerve injuries. Let me repeat the question if it was not. I'll repeat it. Are there any described loco-regional methods for the correction of sensory and proprioceptive loss at little finger, at the affected little finger, producing functional limitation at the ulnar border in chronic ulnar nerve injury?
Now transfer can be done from median nerve branch of the web third web space median nerve branch can be used for a coaptation of the sensory branch of the ulnar nerve.
Yes, that is one of the methods. Do you know any other method?
Superficial radial sensory nerve. Superficial branch of the radial nerve can be used for coaptation.
Yeah. So, and additionally, there is a method described by Anderson, which talks of a neurovascular cutaneous island flap from the ulnar side of the pulp of the middle finger to the pulp of the little finger in patients with chronic ulnar nerve injury.
Okay.
Yeah, thank you.
Thank you.
Next team.
In BJMC Pune. Team 11, Philpop Medical College, Chennai.
BJMC is
Good evening. Ma'am, this is from K-Park Medical College. Can I proceed with my question or should I wait for BJMC, ma'am?
Sanya?
Yeah, BJMC is not there, ma'am. Philpop can ask you questions.
Yeah, you announce like that.
Good evening. This is Dr. Sai Karthik from K-Park Medical College. My question is, what is paradigm galvanic test, and post-surgery, what is the stimulation which we use to do based on this test for stimulating the ulnar nerve or the muscles?
Paradigm stimulation is used for the nerve function as such. Galvanic is for the when the neuromuscular junction is when the renovation has happened till there. That time we can use galvanic. Anything to be added?
Are you sure you want to modify something? And what is paradigm galvanic test? Because post procedures, we will be asking the patient to have electrical nerve stimulation,
Yes.
right?
Yes.
So,
please proceed with the answer.
yeah. So, paradigm galvanic test is similar to our Tinel sign, which we see in our clinical practice. So, that will be used to assess the regeneration of the nerve. So, based on that test, if the nerve it is proceeding, then we use the Faraday test if the tinel sign is positive or the Faraday galvanic test is positive. Because the nerve, whatever anastomosis or the coaptation which you have done is positive or it is functional, then we can proceed with the Faraday stimulation. If the nerve is not regenerating, then we have to stimulate the muscles to keep the neuromuscular junction intact so that we can proceed for any other procedures later. So in that stage, we have to use a galvanic stimulation so that the neuromuscular junction stays alive as long as possible. So this is the significance of this. Thank you.
That's what we told.
Next team is Team Mamsi New Delhi.
Good evening. This is Mamsi New Delhi. Can you tell me the difference between arcade of Struthers ligament and clinical significance of each separate?
Arcade of Struthers is present around 6 to 8 centimeter above the olecranon process, which under which the ulnar nerve ulnar nerve is present. It is present between the medial intermuscular septum and the medial head of the triceps. Struthers ligament is present between the olecranon process and epicondyle, medial epicondyle of the humerus, under which ulnar artery and a brachial artery and median nerve is passing. So, arcade of Struthers compression will be seen in ulnar nerve, while Struthers ligament compression will be seen in median nerve compression syndromes.
Yeah, correct.
Next team ESI Faridabad. Team ESIC Faridabad, are you there? They are not there, ma'am. Next team 14 SRMC Chennai. They are also not there. So
Okay. Proceed to next.
Team 15 AIMS Bhubaneswar.
Good afternoon. My question is, can there be a scenario in which there can be no clawing of the fingers in spite of a complete ulnar nerve injury, and what is the fundamental basis behind it?
Yes, when there is anastomosis, that is Martin-Gruber anastomosis, there will be
you mentioned that already.
Ritchie-Cano anastomosis at the level of hand.
What is it?
Ritchie-Cano anastomosis, which is found between the motor branch of the ulnar nerve and the median nerve.
What is its difference between what is the basic difference between Ritchie-Cano and Martin-Gruber, and how can the clinical manifestation change?
Ritchie-Cano is seen at the level of hand. Martin-Gruber is at the level of forearm. So the injury, if the injury is involving the hand, it might affect that anastomosis too.
Yeah, so Ritchie-Cano, as you said, it is fundamentally just they had documented only one anatomical difference, whereas Martin-Gruber can be 4 varied anatomical representations, which can have different clinical. It may not always present as finger clawing with no finger clawing. Okay, thank you.
The last team AIMS Rishikesh.
Hello, good evening. So
Good
my
evening.
question is, can you please describe the Bouvier's maneuver? What is positive and negative Bouvier's?
Bouvier's test is when the patient presents with clawing. In Bouvier's maneuver, the examiner will stabilize the metacarpophalangeal joint of the ring and little finger and ask the patient to extend the IP joints. If he is able to do it, that is Bouvier's, and when the disability angle is 0. If he is able to do it, Bouvier's is positive, and that is called simple claw hand. When he is not able to do it, and when he is able to do on passive extension, when that is called Bouvier's negative, passive positive. When he is not able to do it even on passive when he is not able to do the passive extension also, then we do wrist flexion to check for wrist tenodesis. If he is able to do it, then Bouvier's negative, passive negative. Then that is due to long flexors shortening. If he is not able to do it even after wrist extension, it is due to joint problem as such. That is, tenodesis is negative.
Yes. Okay, fine.
Sanya, all teams are over.
And all teams are over. Next, we can move to sporters, ma'am, actually.
Yeah. You please project that. From now onwards, each session 10 minutes. So quickly diagnose and tell briefly so that the discussion can be done.
Yes, ma'am.
Time starts now.
Yeah, spotter, please.
I should stop
You
sharing.
didn't. Oh, yeah. Now.
I'll stop sharing.
Yeah.
How do you do?
Elderly male patient with
Lesion.
hyperpigmented lesion over the tip of the nose. Most probably basal cell carcinoma of the tip of the nose. Is my diagnosis.
I would like to proceed with the management treatment plan. In this case, I would like to do an excision biopsy with around 5 centimeter margin, 5 millimeter margin. Then I would, it is an excision biopsy. I would like to give to the histopathological diagnosis. For the reconstruction, the options I have are nasolabial flap reconstruction or forehead flap, paramedian forehead flap based on supratrochlear artery. It is a stage procedure. In the first stage, I would do a pedicle flap, and then after 3 weeks,
Flap division.
cartilage. The defect has to be addressed by giving a lining, a support, and cover. So the support I can provide with a cartilage from the ear conchal cartilage. It can be given at the primary stage itself, at the primary stage of repair when I'm reconstructing with the paramedian forehead flap. And after 3 weeks, I would like to divide the flap.
Can I ask questions?
Yes.
Yes.
So you have done a biopsy, excision biopsy, and
Yes,
also
sir.
you're doing the flap cover. Okay.
Yes, sir.
But after doing the flap cover, the margins become positive.
Yes, sir.
What will you do then? Not insufficient. It's inadequate. What will you do then?
Sir, usually basal cell carcinoma is not aggressive. If the margins are positive, then I would do re-excision with another 2 to 3 margins, and I would do a frozen section biopsy. If the margins are clear, then I would like to proceed with the flap.
What is Menick's principle? Menick's principle. Menick's MENICKS. Menick's principle.
Sorry, sir.
Of forehead flap. Have you heard of forehead flap?
Yes, sir. Not sure, sir.
Not sure. Okay.
Can you just avoid this by doing the frozen on the first day itself?
Yes, sir.
Yes, sir.
Can't you see the margins on the first day?
Yes, sir. Since basal cell carcinoma is not aggressive, and frozen section with adequate, excision with adequate margins will be usually sufficient. So we
Yeah,
might.
that's what I mean. What I mean to say is to avoid.
To avoid, we can do a frozen section
section.
biopsy in the primary
Get
stage.
attachment, then you can go ahead and reconstruct.
Yes,
I
sir.
have a small question on your thing. You
Yes, sir.
said you want to put a cartilage graft from the ear. For what? For the contour?
Sir, yes, sir. Cartilage graft
Yeah.
will provide the support, sir.
Support.
Since
For what? For
this,
the contour.
yes,
Underneath the nasolabial flap, which is so thick, do you think that it is going to show?
no, sir.
Your nasolabial flap, is it going to be thick or very thin?
Nasolabial flap can be thin, sir, but forehead
No, as
flap
thin
is
as the nasal skin?
no, sir.
No.
No.
But
So whatever you are putting underneath is not going to show off much.
yes, sir.
So do you think that you need a cartilage?
We can get away without
Without a cartilage.
Yes.
Can you just put a graft, full thickness graft?
Sir, three-dimensionally, we need if the lesion is infiltrating into the
Yeah,
cartilage.
it's exactly the question I wanted to ask you. How deep you are going to go in excise? You said 5 millimeter all around, but you never told me how much deep you will
Deep
go.
margins will be 4 mm deep margin, sir.
Deep margin. No,
Yes,
depth I'm asking.
depth.
Which
Macroscopic.
one you excise?
No, how do
Margins
you
you told,
decide
that
how
is
much
the
thickness
place.
you will go deep?
Yeah, thickness you do.
You can mark 5 millimeter all around, I understand.
Yes, sir.
How deep you will go?
Macroscopically, till the lesion is cleared, we excise, sir. Beyond that, around 4 millimeter deep, we need to clear.
No, macroscopically or microscopically? You are going to excise.
Yes, sir.
When you excise, how deep you will go?
The whole of subunit can be excised, sir.
No, you're planning to excise the cartilage
all
also along
layers
with
to
Skin
remove.
and subcutaneous tissue we will excise.
Yes.
And then what
You see from which layer of the skin? From which cell?
Basal cell.
Is it deep to
Cellular.
squamous?
It is at the level of basal
What is
cell of the
histopathology?
epidermis.
Yeah, so that means the whole thickness of the skin you will excise.
Yes, sir.
Anything else underneath?
Subcutaneous tissue.
Subcutaneous tissue. Will that be enough?
It will be enough, sir, because
Correct.
BCC is
Be
less.
bold. You are doing well. Both of you are doing well. Be bold.
Yes, sir.
Yeah.
Yes.
It's enough. Now you can send it for frozen
Histopathological examination.
and see the deep margin.
Yes, sir.
Then you will know whether you are exposing the cartilage or not exposing the cartilage.
Yes, sir.
Depending on
Is
that,
it-
you can go ahead with your plan.
Is there any modification of the surgery you are doing now? Is there any modification can be done? What is most chemosurgery?
Most micrographic surgery.
Micrographic surgery, yeah. MMS.
Yes.
What is that? How it is done?
We can excise the lesion layer by layer using microscope, and we have to excise the lesion till there is no malignant cell is visible in the uh, bed of the wound.
So what is the advantage of it?
So usually it is useful in the face malignant lesion. It will minimize the excision of normal tissue itself, and it will minimize the defect size.
At the same time, you can give the clearance.
Yes, sir.
What clinical type is this?
Looks like nodular type of BCC, sir.
What about the thin area of the pigmentation? Is that very vigorous or it is less vigorous?
Less vigorous, sir.
What is the most vigorous type?
Superficial spreading.
This is superficial. Spreading is yes. What else? What are the types?
nodulocystic morphea BCC.
What did you
and
say?
Morphea form is more
That
aggressive.
is more vigorous. Yes. Okay. My question of full thickness graft, you not answer.
Sir, full thickness graft.
FTSG, if there
Yes.
is a recurrence as the process in the last, it can easily be eaten. Now you are putting a big thick flap, it will look like a nodule over the.
There will be.
If there is exposure of the cartilage, then I will prefer flap.
Yeah.
Then if there is no exposure of the cartilage, then we can go ahead with the FTG.
Okay. Are there any local flaps possible?
Nasolabial flaps, sir.
Local flaps. Local flaps.
Bilobed flaps, sir.
Bilobed.
What is the restriction of the bilobed flap?
Bilobed flap, usually for Indian skin, it is not very aesthetically pleasing.
Or restriction in the size of centimeters excision. How much?
Even a forehead will not be aesthetically good.
Yes, sir.
Be very thick,
So,
be a bleb. You have to have thinning, etc. later.
It should be within 0.5 centimeters, bilobed flap.
it should be around 1 to 1.5 centimeters. Then only we can go in for a bilobed flap. Okay. So
Yes.
suppose what could be the clearance for this patient? Suppose if you are giving a 0.5 centimeters margin, how much could be your lesion, excision, post-excision defect?
Post-excision defect will be around 2 by 2.5 centimeters, sir.
Have you seen any dorsal nasal flaps and all? What is dorsal nasal flap?
Not sure.
Not sure.
The time is over.
Yes.
We can we proceed to the next session? Tanya?
Is the screen visible?
Yes.
Yes,
ma'am. The X-ray of right leg APB showing a comminuted fracture of the both tibia and fibula with X-fix in situ.
Uniplanar.
Uniplanar X-ray.
Uniplan with a bone.
Can you comment on the soft tissue also?
Yes, sir. The soft tissue is showing there is a gross disruption of the soft tissue, probably Castillo type 3B. So even after fixation with X-fix, there is a visible bone gap without sufficient alignment of the cut bone ends. So first, I would like to ask my orthopedic colleague to realign the X-ray with the cover of the bone defect with any bone cement, and I would like to do a flap cover once the orthopedic intervention is over. In this case, it is a lower one-third leg defect, so my options are limited, and I would probably need a free tissue transfer.
There are so many bony fragments which you are seeing on the X-ray.
Yes, sir.
What will you do with those fragments which are visible?
Sir, the orthopedician should realign the X-fixer with reduction of the bony fragments.
These are all no separated fragments. Will they align with the external fixator?
No, sir. They might have to excise and bridge the gap temporarily using a bone cement. Then once the flap cover is done, once the wound is stabilized, they can proceed with bone lengthening procedures.
In other words, what determines that you can excise this bony fragment and what you need to preserve the bony fragment? How do you determine that?
If the bony fragment is not attached to any soft tissue, it is preferable to excise because eventually it will get infected and osteosclerosis would happen. So, if it is attached to any soft tissue, then they might have to do a plating and align.
Plating in a open fracture, Gustilo Anderson 3B?
No, no sir. Plating is not an option.
Suppose
Biplanar exposure.
The orthopedic surgeons will hand over this patient and say that this is what we have achieved. Now you take it on from here and try and reconstruct this. What should be the options available to
We
you?
have an option of pedicle free fibulas, pedicle fibula, fibular bone, along with FHL muscle that can be transposed from the adjacent fibula, provided that it is not in the trauma zone.
In this patient, the fibula is already fractured.
No, sir.
Opposite side.
Opposite side can be done if the fibula is also in the trauma zone.
So how will that become a fibula?
Pedicle fibula.
No, sir.
How is this pedicle?
Pedicle if
No, we are talking of this patient only. The X-ray we are
Yes.
seeing. No, we are not talking of hypothetical
Yes,
situation.
yes, sir. Yes, sir. This patient probably it is not possible because the fibula is also fractured and there is a gross soft tissue injury. So free fibula will be an option. Free tissue transfer from the contralateral leg of the fibular bone with the FHL muscle and overlying skin can be used, sir.
Any other option?
Iliac crest bone graft, vascularized, not vascular.
Any other option? So iliac crest will give that much of bone stock?
No, sir.
Then some patient says, no, I don't want the fibula to be taken from my other side. My one limb is already injured. And I don't want fibula to be taken from my other leg. He's very apprehensive. So
Parascapular,
Do you know any banks?
Allograft.
Bone bank. Bone bank can be utilized, sir, where cadaveric bone can be kept.
What about soft tissue reconstruction alone, along with bone transport subsequently?
Yes, sir.
Can it be done or not in this patient?
In this patient, since the fragments are mal-aligned, sir, bony fragments are mal-aligned, we should achieve a stable bone uh, fixation before proceeding flap cover. Otherwise, there is high chances of infection and flap also there is chances of losing the flap.
No. See, he's already fixed it. The orthopedic police has said this is stable enough. They have put an external fixator. Now you're left with the management of the bone defect as well as the soft tissue defect. Okay?
Yes, sir.
You said that I will manage bone defect by using a fibula from the contralateral side and
Yes, sir.
reconstruct the bony segment also and the soft tissue component also, along with the skin pattern. Okay?
Yes, sir.
What I'm asking is, suppose he doesn't agree to that, then what should be your plan in that case?
Sir, We can remove the bony fragments, whichever is not viable. We can debride, and we can do temporary bone fixation using bone cement.
No, bone cement is not a temporary fixation.
Yes.
Why do you want to put a bone cement?
If the patient is not willing for a free fibular graft.
No, bone cement will only bridge the gap between the two ends of the bone. The
Two ends of the
proximal bit. Okay.
Yes, sir.
So that when you want to, in the second stage, when you want to transport the bone,
yes, sir.
After everything soft tissue has settled down, then you can start transporting the bone and remove the bone cement so that the gap is maintained.
Yes, sir.
Otherwise, if you don't put the bone cement, the entire soft tissue will come between the two ends of the bone. And it will
Yes,
not be possible to
and it
distract.
will not heal.
It will not be possible to distract and bridge the gap between the superior and the inferior part of the bone.
Yes,
That
sir.
is the idea of putting the bone cement, not for the purpose of stabilizing the fracture.
Yes, sir.
Okay?
Yes, sir.
So you can achieve, first option is, as you said, that you can use a fibula from the contralateral side. The second option will be to use debride it and use a soft tissue cover along with the bone cement to prevent the gap from getting closed by putting a soft tissue.
Yes, sir.
What is going to be the quality of life of this patient after undergoing so many reconstructions? With
Sir,
because we expect neurovascular injury also in this case, apart
Yes, sir.
from the comminuted fractures and soft tissue loss and all.
Yes, sir.
Ultimately, what is going to be the life of this patient?
Yes, sir. There will be chronic osteomyelitis that is expected complication. Chronic osteomyelitis can present. Um,
What I'm going to tell you is that, which is totally against our reconstructive procedures.
yes, sir.
Is it
He might,
worth saving? Is it worth saving this limb if it has got so many injuries?
yes, sir. He might lead a better life with a prosthetic limb.
Okay.
Time is over, sir. So,
Okay, ma'am, we can go to the next.
Yeah, I think so.
session.
Um, this, this is an instrument showing Rovi's maxillary zygomatic arch elevator. It has a types. The first one has first one has a lever which can be inserted by either Gillies approach or upper buccal sulcus incision, and it is passed under the zygomatic arch, and the lever is used to when we push down the lever, it will elevate the zygomatic arch. The
Whose forceps
The
is
name?
called? Name.
Rowe.
Name.
Rowe. ROWE.
ROWE.
Yes.
Row.
Yeah. What is the role of the outer ring? You have got a sharp side, one side, and then
Yes.
ring-like thing on the opposite and a handle, right?
Yes, sir.
So which side you are going to put it inside?
The ring will be passed under the zygomatic arch.
Uh-huh.
Ring.
That's why I asked you this question. Is it the ring or the sharp side which is going to go in?
That sharp side will go under
Will
the
go in.
arch.
Then why do you need that ring?
To to avoid injury to the skin, sir.
No. How does it help you? You are pushing this underneath the zygomatic arch, the sharp one. This one ring side thing, opposite side is outside. Correct?
Yes, sir.
And then you have got a handle.
Yes, sir.
Now, how will you elevate? Will you lever it on the bone or you won't lever it on the bone?
We will lever it on the normal segment of the bone, and we will elevate the fracture segment till the level of the normal bone.
Then what is the role of that outside one?
Yes, sir. That one we will keep it on the outer margin of that ring. We will keep it on the normal segment of the bone from outside,
Oh.
and we will
Both of
elevate.
them are equal in size. How will you do that? That's not possible. The sharp side goes in.
Yes.
Yes, sir.
Outside is on the skin. The ring is on the skin.
Yes.
Does it tell you anything about the inner one?
Level.
Sir, temporal muscle.
The outside ring tells you the level of the inner one. Because both of them are of the same. If you just hold it like a forceps, the outer end will tell you where is the tip.
Yes, sir.
Because you can't see the tip.
Yes, sir.
The tip is at the depth. So
Yes.
you don't go much beyond. You just go just beyond the zygomatic arch. So the outer one will tell you where exactly you are. Because once you have a depressed fracture, you can't feel the arch. You will go deep to the arch. Now you will know the outer one is going where? That to the temporal area. Then you will know how much you have gone beyond the zygomatic arch. And then that can also be used to little bit lever without much of a pressure on the normal bone. So that is the answer which you have to know. And forget it, without that extra extension, only that handle and the sharp side is there.
Yes, sir.
What is that? The same instrument without that, what I described you, that handle, only the sharp side and the handle is there.
Yes, sir. That is also used for elevation of the
Correct.
arch.
What is that called as?
Dingman
No.
elevator.
It's called as a Bristow elevator.
Bristow.
This is a modification of Bristow. Because Bristow you got to lever. That means you are going to cause hurt to the normal bone. You may fracture if you are more harsh. So to prevent that, you know exactly where you are because of this. This is the Rouse modification of Bristow's elevator.
Yes, sir.
Doctor, you told no, and the Rouse you are using in the another approach also. Keynes also you are using. Huh? Is it necessary? No, he said there are two approaches to approach the arch, isn't it?
Yes, sir.
Yeah, you told about. You also it can be used in the mouth also. You can.
That is not possible with this.
It's not possible. Why do you do that? Okay. You understand what I'm telling?
Yes, sir. Gillies is the commonly done, sir.
Gillies is the commonly done. It is mainly by the Rose. Okay, why do you use it for the Keynes? No.
Keynes.
Yeah, so there is no need. Why? What is the purpose of having that outer ring? That is that ring, the bigger ring. What is the purpose of it? The bigger ring.
Why it is modified actually?
Why it's modified? What is the main purpose of modification?
Modification. Why?
Why?
What will be the complication they noticed with
the injury to the frontal and temporal branch.
Frontal or temporal?
Temporal branch.
Petrous temporal.
Bone, madam.
Bone.
So bone. Okay. So the junction of the outer ring, the junction of the inner side where you are keeping the handle, that acts as a lever. Acts as a fulcrum. Fulcrum. It's a fulcrum, and then in the fulcrum only you are just elevating, isn't it? You
Yes,
are
sir.
not. So by holding the small ring, you are putting it as a fulcrum, and then you are lifting it, isn't it? So
Yes,
that's
sir.
why you have to do the elevation. Okay.
So no pressure on temporal.
Yes, sir.
So what is the plane of the elevation?
Fully introduce the plane.
How will you introduce the plane of the, what is the anatomical plane you introduce this rows? Where exactly
So we
you
have
will
to
introduce?
inside the skin.
Inside then
Between the
what?
deep temporal fascia and the uh, temporalis muscle.
Correct.
There are two fascias will be there, no? The superficial temporal,
Yes, sir.
Yes.
temporopharyngeal fascia and deep temporal fascia. Which one you will
Deep
incise?
temporal fascia.
So you will see
Superficial
the
temporal
muscle or
fascia
not?
will be inside.
You will be incised,
Yes, sir.
and then
We have to see the muscle.
see the muscle, and then you have to go. No.
Yes, sir.
Where do you place the incision?
2.5 centimeter above and lateral to the helical root of helix, sir.
What precaution?
So we should avoid injury to the superficial temporal artery.
So your incision is placed between. Correct. What you said is
Yes,
right.
sir. 2.5 centimeter.
No. Between. You said something to prevent injury to.
What?
Superficial temporal artery.
So you put between.
Between the superficial superficial and the deep temporal fascia.
Between the two branches of the superficial temporal. It branches off their anterior and
Posterior branches.
So you have your incision should be between these two.
Between the anterior and posterior branches of this.
Is it vertical or horizontal?
Horizontal.
Horizontal.
So this is operative, so I would like to ask.
What is the continuation of the deep temporal fascia in the face?
Smash layers.
So what then the temporopedial fascia? It continues as what?
Smash. What is it?
That's also smash.
Yes.
So
Below the zygoma, zygomatic arch.
Deep cervical fascia.
deep cervical fascia. I'm asking you the face.
Yes.
I am giving you the clue. Below the zygomatic arch.
It will split into enclose the parotid glands.
Closely coming.
Anything else there?
Not sure.
Why are you not fixing the zygomatic arch? No, you were just going elevating. But why don't you put a screw? So see, everywhere you are doing the zygoma and everything. Are you doing? Why you are not doing the fixing with the screws, patent screws? But exactly what is the zygomatic arch? What is the anatomy of the zygomatic arch? Bound by what?
Sir, it is a closed space. It will not disimpact after elevation, sir.
Oh,
For
that,
anything to displace, what do you want? For anything to displace in a fracture, what displaces a fracture?
Muscle pull will displace the
What muscle is there attached to zygomatic arch?
No attachment to the zygomatic arch. So
once you reduce,
once we reduce, there won't be any
muscle
pull, so it will stay in position.
So what is the course of the frontal branch of the facial now? Any surface marking there?
Yes, sir. Pitangi's line, which is 0.5 centimeter from the tragus, passing point 0.5 centimeter lateral to the lateral eyebrow region. That course is the frontal branch of the facial nerve.
So once you have got the closed approach is there and it's perfect. Okay. So why do
Yes.
you open? No, open. No, that is will be injuring the
Yes, sir.
frontal branch
Injury
of
to the
facial
frontal
now.
branch.
Yeah. So it always is better.
Yes, sir.
The time is over. So
Yeah, only one question. What is the second one is called as?
So
Second
is it
instrument.
Second instrument.
Gillies?
Yeah, okay, that's okay.
Christos.
It's Gillies.
Christos Pereira. It's not Gillies.
Okay, sir. How much percentage? 80 plus.
back and the left lower limb is not involved.
18 plus 18.
This
36.
this is an adult male patient
36 plus 18.
with burn injury involving around
54%.
around 60 percentage 60 percentage of body surface area with facial burns, and the patient is already intubated. We can see an endotracheal tube in situ. Probable mode of injury would be thermal in this case, involving around 60 percentage burn, superficial to deep thickness in burn involvement. So my management would be, since the patient is already gone to a primary care center and is being intubated and brought to us, I would like to know the fluid management given by them, and once he is approached our center, I would calculate the fluid requirement according to modified Parkland's formula after securing two wide bore lines, peripheral lines. If that is not possible, central line access is sought, and I would like to start him on ringer lactate uh, according to his body weight and burn surface area. First half would be provided within 8 hours of burn injury, and the second half will be given over 16 hours. In the meanwhile, I would like to monitor his urine output, and since the patient has facial burns, uh, I would like to evaluate his airway and rule out.
So once we have given emergency treatment, I would like to do a medical legal documentation person, and I will take a detailed history from the attenders, and I want to I want to take the iris consent from the uh, attenders, and I want to
Diagnosis and
explain the
management test.
diagnosis and the management of the 60 percentage of burns in this patient.
The patient is already intubated, so I would put him on ventilator access, and would ask my anesthesia colleague to monitor.
Why do you think this patient has been intubated?
Probably the patient has respiratory burns, sir.
Inhalation burns.
Inhalation burns. So he would have presented to the primary center by um difficulty in breathing.
Now, you tell me what are the features of inhalation burns, and what are the indications for doing intubation?
So features would be singed nasal hair and carbon soot will be seen in the oral and nasal cavity. Then tongue edema.
And history of burns in the closed
Closed
room,
space.
closed space, and hoarseness of voice, and breathing difficulty, and carbonaceous sputum.
Okay.
And
What are the indications for intubation?
um, when the respiratory rate is above normal range, that is 16 to 20 cycles. If the respiratory, when there is tachypnea, when there is reduction in saturation, when there is low saturation, um, we would proceed for intubation, sir.
What are the problems with the inhalation burns?
The airway become edematous, and it will be difficult to do intubation if we. So better to do prophylactic intubation to prevent difficulty intubation in the later stages.
Yes. So you don't have to wait for the patient to develop breathlessness and difficulty in breathing.
No, so primarily we can proceed.
So if you are suspecting that patient has got inhalation burns, it is better to do a prophylactic
intubation
and secure the airway.
Yes, sir.
But normally these patients, they do not give you enough time to react when they have sudden difficulty in breathing because of the severe edema which takes place, both laryngeal as well as tracheal edema which takes place.
Yes, sir.
So, and if that is the primary cause of death in the within 24 hours in these kinds of subset of patients. So you must try and secure the airway as early as possible if you suspect that patient has got inhalation burns.
Yes, sir.
Okay.
Is Parkland formula absolute or relative?
Sir, Parkland's formula, he uses 4 ml per kg
No,
body
I
weight.
know. But is that absolute or it is only a guideline for you to start?
It is only a guideline, sir. Depending on the urine output,
So
we
what
can.
is missing in this, in your management? You have not passed a catheter at all.
Yes, sir. I mentioned.
No, in this patient.
Yes, sir. Yes, sir. After we should monitor the urine output with catheterization.
What is the urine output which you?
1 ml
1 ml per kg body weight.
Is
In
it
case of adults.
for all weight? Or minimum is what?
Minimum is 1 ml per kg body weight, sir. 1 ml to 2 ml.
0.5 ml per kg body weight is the minimum.
What will be the weight of this man?
Around 60. Around 55 to 60 kgs, sir.
55, yeah.
Yes, sir.
And same 4 ml if it is a 90 kilogram person?
No, sir.
Ah.
It will.
It will the Parkland's formula
90
way.
kilogram we can get.
It will. Parkland formula same or is there any restriction for the weight?
There is no
restriction for the weight,
sir.
but
There is a restriction for the
percentage of burns.
burnt percentage.
Maximum
Up to
we
what
can,
percent you calculate?
50% is the maximum.
Correct. So you said 60% for this. So you will have to calculate for 50.
50%.
50%. Yes, sir.
You're suspecting inhalation burns, no? So what's the blood test you'll be doing initially when the patient arrives?
Carboxymethyl hemoglobin.
Carboxyhemoglobin, no?
Yes,
Carboxyhemoglobin. How much?
Carboxy.
What is the normal? Any idea? What is the normal and how much? Yeah.
I'm not sure, sir. Third, maybe 10 to 20. I'm not sure, sir.
And how will you manage inhalation burns? Any specific treatment available for inhalation burns?
So we would manage. We should reduce the edema by giving intravenous steroids. Hydrocodone dexamethasone can be given, sir.
Nowadays they are using heparin nebulizers.
Heparin nebulization can be given, sir.
Nebulization
Heparin
can be done.
nebulization can be
Yeah,
given along
can
with
be given.
N-acetylcysteine.
Yeah.
Oh, you said about the urine output. Is it every hour you measure? And you every hour you adjust the IV?
Yes, sir.
Or is there anything else?
We measure every hourly, sir, and
you adjust every hour?
yes, sir. We have to adjust every hourly if the urine is high colored and not sufficient.
Or every 3 hours average?
Every hourly would be better for this case, sir, since it is already 60% of burns. The fluid loss will be rapid and
No. The point is this. This hour is 0.
Yes,
Will it
sir.
now increase immediately? Next hour is 80. So immediately you will change, or you will change it accordingly?
Once it is changed, sir, I would like to give some time for the
For it to push.
renal. Yes, sir.
Okay.
Renal shutdown would have happened, so I would like to give some time for the recovery.
If there is pain, what sedation you will give? How will you give?
Opioids are preferred. In this case, IV tramadol can be given, sir.
Opioids, does it produce depression of respiration?
Yes, sir. Opioids, as such, they will produce depression of respiration, but
This patient has got a respiratory burns also, if you think. Will
yes,
you
sir.
give opioids?
Morphine would cause, sir, but other
Tramadol and fentanyl will have.
Fentanyl can be given.
Will be.
Okay, good. I think 10
Anything
minutes
for
over.
wounds?
Ma'am?
Any treatment for wounds?
Yes, ma'am. So silver sulfadiazine dressing can be done. The
Yes,
other, if other options are not available, better option would be foam dressing. Foam dressing, which is silver coated Mepilex AG, are preferred.
Very expensive.
What is
all
standard
types of
electrician?
available, all materials available to you.
Yeah.
What is standard electrician of the burns?
Tangential excision can be done in the acute setting within 4 days of burns, where we can use a skin grafting blade to excise the burn surface area tangentially. It is done only in partial thickness burns, partial to deep thickness burns. We can do it, and till the tangential excision is done till pinpoint punctate bleeding is noted, and that area can be immediately grafted. This would prevent the this
What is
would
the advantage?
aid in faster healing, sir.
It will reduce the bio burden of the wound.
A
Okay.
burden of the wound.
Bio burden of the wound.
Yes, sir.
But it can be done straight away for this patient.
No,
Can
sir.
we
Once
do
the
that?
patient is stabilized, then only we have to plan for tangential excision and grafting.
Would you reserve blood?
Yes,
Yes,
sir.
sir.
How much?
So tangential excision in the peripheral, in the limbs, we can do it with a tourniquet, but we would not be able to see the.
No. My question is, how much of blood loss you will calculate and replace?
In this case, at least 2 pints of PRBC would
No,
be.
come on. My question is, how much you will excise? 10%? 20%? How much you are giving?
In one sitting, till 20% of the burn surface area can be
Okay.
excised.
So
Sir.
what will be the loss per percentage, roughly?
30%.
For 1 centimeter square, 1 ml of blood loss will be there.
It has got anything to do with calculation of body weight and percentage. The rough calculation. Anyhow, it doesn't matter. I think all these are a little bit more for information. That's it. Roughly about 3 ml per kilogram per percentage.
Kilo. Yes, sir.
That means 3 into 20 is 60. 60 into 60 is about how much it is? 360. Then I may not much. It
Yes,
all
sir.
depends. Again, about 500 ml, you need not replace. Above that 500 ml, you have to replace.
Yes, sir.
You mentioned about silver sulfadiazine. What are other topical antimicrobials used in burn dressing?
Silver nitrate.
Not used.
Zinc oxide.
Not used.
Methylene.
Methionide acetate.
Mefenamic acid.
Not in common use. Which is commonly used, especially in the developed countries. We can also use, it is available. What are nanocrystalline silver dressings?
Silver nanocrystals, sir, can be used.
Have you seen it?
Yes, sir. It
What are the
is
yeah.
available in ointment forms these days.
No, it is not available in ointment form. What is they're available as, Acticoat, like that, trade names?
Yes, sir.
Mepilex.
Yeah, same, similar
Mepilex
kind of
AG
thing.
has
Mepilex AG, Aquacel AG.
Aquacel AG.
What are the advantage of these dressings over the silver sulfadiazine?
They can observe the exudates also, sir, to certain extent. So frequent dressing change will not be
And there
required.
will be sustained release of the silver
ion, which will aid in healing and avoid infection.
What is this main disadvantage of using silver sulfadiazine?
Soda ash formation will be there.
Number one. It requires frequent dressings, isn't it?
Yes, sir. Frequent dressings.
What should be the frequency?
With Mepilex AG, Aquacel AG, and for silver sulfadiazine, almost every day dressings might be needed in
So every day when you do dressings, you are rubbing the wounds. So whatever the epithelial regenerates,
that
is
will
damaged.
also be injured.
That is damaged.
Yes, sir. Yes, sir.
Isn't it? Secondly, you whenever you open the dressings, if you open too frequently, you are introducing the infection from outside, cross infection, like that.
Pain.
So that's why the nanocrystalline silver dressings are better. The dressing change is not every day. It can be alternate days or even after 2-3 days of, depending upon the condition of the wounds.
Yes.
Okay.
Yes,
So
sir.
this is also important to know, that what is latest available in the wound management, apart
Yes,
from
sir.
tangential excision and all.
Yes, sir.
Patient comes early and availability of collagen, you can consider for collagen.
Collagen. Yes,
Time is over.
What Benedict's formula? Just tell Benedict's formula. Just last question. What is Benedict's formula?
Benedict's formula for colloid
Nutrition.
nutrition.
After burns.
Nutrition. It is calculated 40 mg per kg into plus 60 grams. 60 grams of protein per kg body weight.
Okay. Right. Move on to next.
Next session.
Okay. Right.
Well, can I have a question, ma'am?
Yes.
Yes, sir.
Yeah. So my question is, in this patient, to quantitatively assess the hydration, what could be your investigation method apart from the urine output?
So
Hematocrit.
CVP.
Hematocrit, no.
Central venous pressure, sir.
Yeah. So that is called central manometer.
Central manometer.
So how much will be normal? How it is calculated?
Sir, it is calculated by insertion of
Swannick catheter. It is
Swan-Ganz catheter
catheter.
through the internal jugular vein.
Yeah, very good.
Normal is 7 to 10 millimeters of mercury.
Mercury or water?
Water.
Water, sir. Water.
Then the last question,
Centimeters of
what is the most recent method of treatment of any major burns? Even 95%, they are doing the most recent method of treatment as far to prevent the translocation of bacteria from the intestine for preventing the septicemia.
Hyperbaric oxygen therapy.
No, they are putting the nutrition from day one with a nasogastric tube.
Yes, sir.
So that
Enteral
is
feeds
most
are started from the day one.
Yeah. Thank you very much.
Thank you, sir.
Thanks.
Good.
The picture showing the complete amputation of the uh, left hand at the metacarpal level with complete amputation of the left thumb. The amputated part includes all the 5 digits.
Hyper
I will counsel the patient and patient attenders. I will explain the management options. That is a replantation of the amputated part, and the post-op follow-up of the and I will explain the post-op follow-up like physiotherapy and everything, and I will explain the chances of failure of the replantation, and if there is a failure of the replantation, and what will be the secondary procedures for the remaining stump.
The patient gives consent.
And if the patient gives a consent for the replantation, I would like to go ahead with the replantation of the amputated part with the microvascular anastomosis of the uh, radial and ulnar vessels, and cooptation of the digital nerves, and uh, bony first bony fixation with the K wire, and extensor tendon repair, flexor tendon repair, then digital nerves, then vein anastomosis, and finally digital arterial anastomosis. Then the post-operative care, I will monitor the uh, post-op replanted part, every early urine output and vitals of the patient, and the vascularity of the fingertips, and I will start the patient on IV fluid along with the heparin infusion for 48 hours. Then if it is a vascularity is good of the digits, then I will change the heparin into the uh, uh, antiplatelet drugs along with the enoxaparin. After uh, 2 to 3 weeks, if the replant is good, then I will start the patient with the physiotherapy, uh, initially with the passive physiotherapy, fasciflexion, and later gradually I will start active and passive physiotherapy of the all digits. And if there is a failure of the replant, then I will go ahead with the flap cover of the amputated stump. I would to prefer do a groin flap cover for the stump to cover the stump area. After the 3 weeks, I will divide the flap. After the 3 months, then I will plan to reconstruct the fingers with the second toe to finger toe transplantation.
I think we must confine to this
Yes, sir.
because it's only a short, 10 minutes sessions.
Yes.
Yes.
So we'll confine to this.
Yes.
You said two things. You said ulnar and radial artery. Then finally, when you are talking, you said digital vessels. So I just want to know, where do you think the cut is?
It is at
It's
the
a level
level
of superficial Pamarach.
Very good. Very good. Excellent. What made you think that?
The Kaplan's line, sir.
What is that line?
The line passes from the first web space radial aspect to the pisiform bone that will denote the arch.
Yeah. Fully abducted thumb, I think it is easier for you to, right? Along the
Yes.
web.
Yes,
So
sir.
somewhere here must be the superficial
Yes.
palmar.
Yes,
But
sir.
the question is 1, 2, 3, 4 is what is your stepwise operative management? That was the question. What has been written there. So
Yes, sir.
what is the first step? What is
First
the second
step
step?
will be securing if the patient if it is a polytrauma, we should address all other ABC management, airway, breathing, circulation. Then we should get an IV access for the patient. Once the patient is stable, another team will be simultaneously looking at the amputated part, and they would check the amputated part. Start the debridement, and we can delineate the vessels and the nerves and everything simultaneously. Once a patient is stabilized and fit for surgery, once the patient once the blood investigations and all are sent and retrieved, we can, after consulting with the anesthetist, we can take the patient to the OT. Meanwhile, the amputated part of the stump, amputated
See,
part.
such details are not required.
Yes, sir.
Just tell 1, 2, 3, 4, 5. What is the first thing you need for this?
So we will do the debridement of the
No,
both the
before that.
we will
Before even taking him to the OT, I need one more, at least basic investigation.
Dressing.
not vascularity.
Basic investigation.
Store the
Investigation is asking.
Very basic.
Doppler.
Very basic investigation.
CBC to check for blood loss, sir.
Very basic.
It will tell you the level of amputation.
X-ray.
X-ray.
You need to have an X-ray first. I was about to ask you, what do you think is the bony fractures at what level? See, let us think in a normal way. Don't expect me to ask you very fantastic things. Just ordinary thing. You have to fix the bone, so you must know where the bone is.
Yes, sir.
Okay. That you tell where the vessel is.
Yes, sir.
Where the tendons are.
Yes, sir.
Yeah, that is that way I want you to answer. Where the bone is in thumb. What level you think?
Thumb
is
at the level
proximal phalanx, proximal to IP joint.
Proximal to head.
Proximal to IP joint.
Yes, sir.
That's
Head of the
fantastic.
proximal
That's
phalanx.
okay, enough.
Yes, sir.
And index middle ring.
Yes, sir.
It is
Where?
at the level
At
of
the
shaft
level-
of the metacarpal bone.
Shaft, just distal to base.
Yes, sir.
Yes, sir.
Okay, little finger.
The
I don't
level
know
of
whose face is
MCK
that. It may change in their X-ray, but at least little finger. What do you think it is?
at the level of metacarpophalangeal joint, sir.
Yeah, just proximal to metacarpophalangeal joint or at the level of metacarpophalangeal joint. You look at this skin. You haven't.
There is.
Crease is there. Skin crease is there. Seen.
Yes, sir.
Yes, sir.
So that is the level of MP joint.
Yes, sir.
So fine. Now, next step. You got an X-ray. You know what it is. What is the next? In steps, you tell I'll fix. I'll do this. Like that tell. Don't give big discourse, Just answer. What is the next thing you'll do?
Yes,
Debridement, yes.
Debridement has to be done, sir.
Then
What?
shortening of bone. Shortening of the
bone.
bone.
Yeah. Will you distally shorten or proximally shorten?
Distally, I will shorten the bones.
Distally, you will shorten. Little finger. Distally, MP joint is there.
Just.
Thumb.
Then I will
It is
shorten.
very close to IP joint.
Since the proximal part also is injured, sir, that also can be shortened.
Which one you will shorten depending on whether
proximal
close
part
it
in
is
the.
or proximal it is. Okay. Right, you shorten then.
Then I will fix the bone with the K wire.
I think Dr. Sendil is asking something.
No, sir. No, sorry.
Okay.
I fixation of the bone with the K wire or external fixator.
External.
External fixator.
After that, I will repair the extensor tendon.
No. K wire. You stick to that. Okay.
Okay, sir.
Stick to K wire. Okay, you're passed. Then, next one.
I will repair the extensor tendon. Then flexor tendon repair. Then nerve cooptation.
Tendon, you have to first identify the proximal end.
Proximal and distal ends we have to identify.
So these are the steps. Identify the where do you expect the proximal end to be?
It will be in the zone 5 region.
It would have retracted and gone to the zone 5 region, sir.
Forearm?
At the forearm level, sir. Zone 5 region.
So will you make an incision there?
Yes, sir.
Without that, we can try to retrieve through.
I will put an incision, sir. I will put
Can
an incision.
you see the lumbrical there?
Yes, sir.
Yes,
FDP
sir.
will be. We can retrieve FDP from this level itself, but for FDS and apart from FDP, all the tendons will get retrieved in the forearm. I will put incision to retrieve those tendons.
I said you see the lumbrical there. That means the cut is proximal to it. Lumbrical cannot hold it. Therefore, FDP also would have retracted.
Retracted.
Okay, you identify everything, tag it.
Yes.
Which are the vessel you are going to anastomose?
At this level, we can anastomose the ulnar artery and
radial artery. What about the thumb? And what about the little finger? What do you think? Just
we have to identify the digital vessels for both the thumb as well as little finger, and we have to do digital artery anastomosis for these two fingers.
Arteria princeps polliceps, which supplies that.
Princeps pollicis will supply
it is from
thumbs.
where?
From the. It is a branch from the arch towards the thumb, sir.
Which arch?
Deep palmar arch.
Yeah, but these are all branches of
radial artery.
Superficial.
No. The fingers.
They are from superficial palmar arch.
So there is a deep arch now, which is cut or not cut?
It would be cut, sir.
Sir, time is over, sir.
Yes.
Last question, in fact, counseling means you should have told about the timing. What was the ischemic time? It is a cold and warm ischemia. That should have been told to the patient attendants.
Yes, sir.
That was in the counseling most important.
Yes.
Yes.
Because the outcome will depend on that also.
Yes, sir.
Okay. Next case, I think.
Really?
Uh, there is a female child with the leg dystocia of dog bite with the sustained lacerated wound over the face. It's a There is a two cut lacerated wound measuring about approximately 7 into 6 centimeter, and
We should address which dog. At what time?
over the left cheek, and around 8 into 4 into 5 centimeter cut lacerated wound over the right cheek. Um, and I will ask the proper history from the kid attender. Uh, what is the time, place, and what is the time and place of the injury, and
Street
what
dog.
whether the dog is street dog or immunized home dog.
Whether primary care is taken.
And whether the patient went to primary health care before coming to this hospital, whether the baby is immunized with anti-rabies vaccine, immunoglobulins. Um,
No.
This is a fresh injury or is an old injury?
it is looks like fresh injury.
Looks like a fresh injury, sir.
So you tell us, no, she has come to you as a first time presentation.
Yes, sir. The injuries involving the bilateral cheek region and also the right angle of mouth, oral commissure, and it is also at the region of vital structures like facial nerve, parotid duct. All this could be damaged. So I would like to examine the patient. Since she is a child, my examination would be little guarded, and I would ask her to, if she's cooperative, I would ask her to do the expression of all the facial muscles to rule out facial nerve injury, and thorough wash of the wound should be given along with anti-rabies vaccination, along with immunoglobulin administration. Um, then as soon as possible, the patient should be taken up to theater to under general anesthesia, and debridement of the wound should be done, and rule out any injury to the facial nerve and parotid duct. If primary repair is possible, we can proceed with the primary repair after giving a thorough wound wash.
Any documentation, no?
Documentation.
That is what is the question, I think.
Yes, sir.
Documentation.
I would ask the patient attenders about the injury, where the injury has occurred and when the injury has occurred, whether it is an immunized dog or a street dog, whether the history as such is reliable from the patient parents, and I would make an MLC documentation of the injury.
Fine.
You will also document whether it is a unprovoked
Unprovoked dog or
provoked.
provoked dog.
Or provoked. That
Yes,
will give
sir.
you some idea about this.
Yes, sir.
So is it possible for you to document all the injuries this child, because child I don't think will be cooperative to allow
Yes,
you?
sir. The child might not cooperate. Whatever is visible, and when the child is crying, maybe we can make out the facial nerve injury.
Take a picture and document.
Yes, sir.
Okay.
Over. All sessions are over. So now, any questions from the delegates or other faculty? Any questions in chat box, Sanya? I think they are answered almost.
They have done a very good job. I think I must first congratulate them.
Thank you,
Thank
sir.
you, sir.
They have done a good job.
Thank you, sir.
You have read well.
Thank you, sir.
You need little polish. That's it. That's all.
Yes.
There's a question, should we do immediate suturing?
Somebody has asked a question in chat
Yes, sir. Should we
whether
do
you would like to
immediate
immediately
suture in
debride and
long?
suture or not.
Sir, there are different schools of thought when we can give a proper wound wash with anti-rabies immunoglobulin and anti-rabies vaccination at the same time. We can proceed for a immediate
closure.
primary repair.
Face will you not repair? You
Yes, sir.
debride and repair.
We need to repair,
I
sir.
don't think you can just keep quiet without repairing this for even
Yes.
2 days or 3 days. What is now the latest thing is local application or
Local infiltration of the anti-rabies immunoglobulin, sir.
immunoglobulin. Yes.
Almost all centers, the repair is being done. Now we are not face wounds, we don't leave like that.
Yes.
The delegates can now unmute yourself and ask questions now.
Well, in this case, the patient comes half an hour after the injury. So how do you administer anesthesia? Patient has taken in last meal or whatever feeding has been done.
Sir, IV anesthesia.
Then we have to.
Patient has taken the
It
meal.
is not. Then we have to wait for 4 hours. If there is a
Patient attendant is very much worried. He wanted the operation should be done as early possible. He will pay you more money if you do it early. It has happened in one of the hospitals in Mumbai when in our conference of microsurgery. So that's why I'm telling you how time factor matters with the relations.
Yes, sir. We need to counsel the patient's attendant.
Yeah, that is the point. I'm asking. That is the point. Counsel not only you can go by nasogastric feeding tube and you can aspirate all, and the anesthesia, general anesthesia can be done.
Yes, sir.
With taking proper precautions. It's not even a big issue. With a good anesthetist can do it.
Yes, sir.
So such things can happen to you. Patient can come early to you. And number two is the documentation. The documentation part is to be, as a plastic surgeon, any patient comes, apart from the photography has already been told by one of the faculties, you need to have a schematic diagram. What
Yes,
was
sir.
the condition when you saw time of injury, nature of injury, all these things has to be documented for further. In the court of law, you may be called for giving your expert opinion.
Yes, sir.
Yes.
And it is a dog, normal dog, or it is a pet dog, or it is a rabid dog. All that history has to be mentioned. You are
Yes,
not
sir.
the person to confirm. The police will confirm, but you have to write.
Yes, sir.
Okay, these are the documentation very important for a plastic surgeon, because in later stage, only the written document will stand and help you.
Yes, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Okay, ma'am, if there are no questions, then we can close in the session.
The sessions are over, sir.
Yeah.
And we have the panelist time now. So I request Dr. Bandari sir to present the videos and inputs.
What I'm going to do is,
Sir.
because basically I'm doing now work, and I would like to show some short presentation which was related to the ulnar nerve. Okay.
Yes, sir.
Yeah. So I'm just going to share the screen.
Till we start.
Not connecting.
Yeah, please give me some time. उनको दिख रहा होगा, वॉइस कर लीजिए, उनसे पूछिए सब दिख रहा है, उनसे पूछिए।
Sir, audio is not there, sir. Bandari sir.
Self-explanatory, I think.
Okay, okay.
Possibly. That's why. Beautiful.
Dr. Bhandari, are we able to hear?
Yeah.
We are not able to hear the audio. Some problem with the audio. Video is okay, but audio has to come.
Beautiful.
Yeah, these are all
Excellent,
self-explanatory
excellent. This is
videos. So I thought I should keep quiet because we have discussed so much about the ulnar nerve and all. Everybody is aware of the anatomy and other things. So I hope these videos will be useful to the PG students.
Yes,
And
it's really nice.
any
Very
questions,
Great.
you know, if they
Great, sir.
want to ask. Yeah, thank you so much.
Sir, you give your analysis about the PGs today's
Yeah,
presentation.
they have, I think both of them have in-depth knowledge, you know. Mm, I was very much impressed by their presentations, and many of the questions which asked from them, you know, I thought probably they may not be able to answer. But to my surprise, they came out with good answers and good presence of mind. They did very well.
Yes.
And, I have, but a certain thing I would like to add when we are discussing about the nerve surgery and all, that we must do under proper anesthesia. The student said we'll do under regional block, which I said no, because most of the time graft is required. We should do under general anesthesia. We have to achieve a proper hemostatic field either by proximal tourniquet control, or if it is not feasible, then we should inject adrenaline. Micro suture, micro instruments, these things were not discussed in the presentations. We should use fine sutures for ulnar repair. If you are doing direct repair, we should use 8-0 nylon suture on micro needle and round body needle. And if you are doing the graft repair, surulnar and all, 9-0, 10-0 suture, micro needle, round body. And minimum use of suture should be done. You know, these days commercially available glue are available. We should use fibrin glue. Our results will be better. Minimum use of suture, because sutures are likely to introduce foreign body, and foreign body granuloma formation have been seen in these patients on histopath studies. After nerve repair, we must immobilize the limb for at least 4 weeks. This is also very important. Nerve surgery should never be done in emergency situations. If we should have a proper setup. It is not an emergency procedure, by the way. Even the patient has come with a lacerated wound, deep cut. The aim should be to control the bleeding at that time and postpone the surgery for the next day. Best illumination, best team, under no compromise. And there should be delicate handling of the nerve tissue that we all are familiar in plastic surgery. I always tell my fellows that nerve repair with or without grafting is like cooking a small fish. Too much handling will spoil it. So with that, you presented both of you very well, and the question answer session was also very much interesting. Thank you so much.
Thank you, sir.
Next, I invite Dr. K. Sridhar sir to give you a presentation, sir. Sridhar sir.
I'll just show you a short video and a few slides. It will take about 7 minutes totally, I think.
Okay.
I am unable to share screen. I think some other screen is there.
No, sir.
I don't know. I'm unable to. Mine is not coming. My layouts. Okay. Is it visible, something?
Yes, yes, sir. visible. Your PPT is
Okay, I'll just tell you one basic things.
full screen, sir.
See, what you choose depends upon what type of movement you want. Thumb adduction and index abduction are important, but not for us, mainly for people who hold a fork and knife. For us, what is required is MP joint flexion, thumb opposition, because we have to hold on to a chapati. We need to have an arch maintenance because we would like to drink. And also, we need to have the cupping of the hand there. And powerful grasp is required for people who hammer. So depending on this, you choose what is the motor. And then choose where you want to attach it. And then choose the route it has to take. So main thing what you have to get back is MP joint to flex and IP joint to extend. Thumb adduction and index abduction are choice, not always required. For example, if you see here, this man without any thumb adduction and abduction, he is able to do the Foreman sign like thing, flexing his thumb. But this is a normal movement. So this is also possible for us to hold on to a key pinch. Therefore, most of our patients may not ask for it. And the reason for Foreman sign here I would like to tell is, the reason is the extensor expansion of the thumb gets contribution from all the thinner muscle. Here you have got a paralysis of adductor thin. Therefore, the extensor is less powerful. That is why the overactions of appear. That is why it flexes. So now left, I choose ECRL or ECRB, provided he is a manual laborer. So he requires a further strength. Therefore, I bring motor force from outside the hand, fingers. That is ECRL and ECRB are outside the hand. Therefore, we are not compromising on the function of the hand by taking FDS. Instead, we are bringing from outside. So we are adding power to the existing power. So I use ECRL, ECRB when it is a manual laborer. FDS I use when there is a thick finger, needs more power but not as much as manual. And PIP is not hypermobile. If it is hypermobile finger and you take the FDS, then it goes for recurvatum deformity. Therefore, you have got to fix the tendon distally. Otherwise, prefer not to use FDS. See, this is what is a recurvatum, a donor side deformity done elsewhere. That is without thinking about it, they have done it. Therefore, it gives us, so this is a very difficult deformity to correct. And EIP, I use it extensively and also extensor for our fine, small hands, children, women, and hypermobile finger, I use extensors. Now, root, whatever is the root you take, it has got to go volar to the metacarpophalangeal joint. And then it might get inserted distally. Distally means what? You can insert it into the extensor expansion, you can insert it into the pulley, or you can insert it into the intrinsics. So you can see here lateral slip insertion. This is flexor pulley, and this is intrinsics. So the guiding principle, as that girl rightly said, is Bowyer test. If the Bowyer is positive, there is no need for you to insert. You can use a static procedure. If the Bowyer is negative, that means the extensor expansion over the PIP is not working. That means you have to repair the extensor expansion, or you give power distal to that. That is required. You have to repair and then give power, or repair and proximally you do a tendon transfer without the lateral slip. So this test tells you only one thing. That means the extensor expansion is intact and it is functioning well. That is the point. Flexor digitorum and sublimis procedure, as I told you, it is a Zankali. Zankali is nothing but you are taking it through the A1 pulley. Beyond A1 into the A2 also you can take and then bend it so that the MP joint flexes. Automatically the IP joint will extend because of the extensor. That is the Bowyer test. The extensors, long extensor expands the IP joint when the MP joint is stabilized. Now you are stabilizing it with Zankali procedure. Automatically the long extensor will extend the IP. Therefore, your problem of MP joint flexion and IP joint extension is achieved. Now this is the procedure you can see here. I'll just quickly short, you can take, you can make a side incision also if you are going to insert it to the slip. If you are inserting in the Zankali, you can open in the palmar side. You can see here, both the slips are cut through the side itself, you can do that. And then the decussation, and then the connections you are cutting off until it gets released from the FDP totally. Make an incision in the distal portion. The important point here is to see that you are leaving the fat back and you are only very thin skin you are elevating. The reason is, otherwise it is very difficult for you to evert the skin and reach that level. So this is what you do. Same way proximally also you do. Now you can see here, sometimes you use it local without tunica, sorry to do that. And then you cut the fat and expose the pulley. Cut the fat and then expose the pulley. This is the area of the proximal entry of the pulley. Distally it goes up to that. This is A1 pulley. I'm just demonstrating it to you by a tunneler which goes up. It goes up to the A2 also. So now at that level, you can pull out the FDS. Both the slips can be pulled out. And then make a proximal incision in the palm and deliver the tendon there. This is just proximal to the level of the superficial palmar arch. Then it is split into 4 tails. And then each one is tunneled distally into the region of the A1, A2 pulley. I normally attach different instruments to different so that it doesn't confuse you. Use a curved artery, straight artery, Alice, and then coccus, so that you know which is lateral, which is medial, and then pull out the tendons into this. And then tunnel the thing through the A1 pulley and take it out through the distal margin. Sometimes in hands-on patient, I just use infiltration and then I don't use a tourniquet. That's why sometimes it is clumsy like this. Yeah, you deliver it like this. And then you pull at it, it will flex the finger. That's it. Same thing you do it. And then pass a silk thread underneath the proximal portion of this. And then pull this up and then just tie it up. You can transfix it or just tie it up. So proximal to the entry of the tunnel, you pass the thread underneath. And then after this is passed distally, you just flex it over that and then just tie it up. Keep it like that and then tie it up. You have to adjust the angle. I keep it around 30 degrees in index finger and 45 degree in little finger, and in between gradually it is increasing the flexion. Just see that I'm adjusting. Now I'm fixing it only at 30 degree. That's it. And then gradually I will increase it as it goes to the little finger to about 45. Like that for all the fingers we have done. And then you can see here, the cascade is beautifully maintained between index, middle ring, and little. That is what is important. And this is the post-operative you can see here. I normally take pictures of both lock opening and also buttoning, because buttoning is an important thing wherein both the hands are used. Opening the button requires a different, and putting on the button requires a different one. Sorry. This is another thing which is important for our country. Even if there is some amount of clawing, you can see here that she is able to do. And then Palande procedure, Palande did it. Not many people have been using it. Then I started popularizing this technique a lot. Here you can see the same thing. Instead of FDS dividing into 4, it is divided into 5. And in between the palmar and dorsal interosseous, between the fingers are looped, and then it is sutured. You can see here. To this, the same thing is looped. Again, I use only silk to just tie it up. You can see here it is looped. And then the 4th and 5th, that is the first one and the 5th one, are sutured to the abductor digiti minimi. Abductor of the first, abductor of first, and then here again the abductor of the little. So abductor, first dorsal interosseous is sutured. Abductor of the index is first dorsal interosseous. Here you have the abductor digiti minimi itself is the abductor. So to those, it is sutured. That gives you cupping. That's all. Then the easier and easier procedures are done for people who are real manual workers. Nowadays, we don't find that much. So I use either indices or I use FDS. Thank you. Any question, any doubts you have, you can ask.
Wonderful presentation.